All right. Guess I better turn this noise off. A. Oh. You guys started working on tracing blood through the heart. Y'all know that yet?
Do I?
Y'all know how to trace blood, a drop of blood to the heart?
That's the direction in which the blood flows.
Yes, the direction of blood flow to the heart. You'll need to know that. Remember I told you there's probably like 3 questions referring to that on the test. All right, we're going to talk about cardiovascular emergencies, which I guess we didn't pick up the other day. I appreciate Chuck picking up all the other stuff he did. Okay, let me see if I can get this thing on. I really don't. Oh, there it is. All right, this first section talks about a bunch of statistics that deal with cardiovascular disease, okay? Now, I generally point out that there's 2 words right there, cardio and vascular. So what we're talking about is not only the heart muscle, we're talking about the blood vessels that supply the heart muscle itself. And we know from talking the other night that those are called coronary arteries, okay? We also told you the other night that the heart is very unselfish and it will beat from the minute you're born to the day you die. It only makes one demand. It says, I want the freshest blood available. So the first blood vessels to split off the aorta are the coronary arteries, okay? Generally, when somebody has a heart attack, it's because one of those blood vessels have been occluded. Okay, that's a pretty high statistic, as 50% of all deaths are cardiovascular disease. So that's probably telling you that 5 out of 10 calls you make where people die are going to be from a cardiovascular disease. Heart attack, MI, sudden death, things like that. So it probably is kind of important to know stuff about the heart because we're going to see so much of it. The other factor that you should consider is that as a population, by the year 2030, 35 to 40% of the population of the United States will be considered geriatric over the age of 65. And so what does that mean to these statistics? They'll just keep climbing, won't they? Okay. All right. That's a word you should be intimately familiar with, AMI. We'll use that a lot, and that's what it stands for, acute myocardial infarction. Okay. And acute, again, is a sudden onset, and then the myocardial is a heart muscle. And infarction, as opposed to ischemia, which we'll see in a minute, infarction means death to that tissue. So anytime you see the word infarction, it means part of that heart muscle has died. And generally the part of the heart muscle that's died is the one that blood vessel is feeding. Okay, and this is an old slide. It says about 1.5 million Americans will have AMIs this year. Do you think, as the fire department, we go on heart attacks every shift? The answer is we do, absolutely. And are they just one segment of the population? Are they just old people? Or are we starting to see that in young people? Are we starting to see it in even younger people? And if we got a call the other day, an 18-year-old that was in cardiac arrest. And the first thing that comes to my mind is either this is a BS call or it really is an AMI. And then you got to ask yourself, why do 18-year-olds have heart attacks? And the answer is? Yeah, drugs. What kind of drugs?
Meth.
Cocaine. Very good. So a lot of these people die. And it says that probably that percentage of people will die within the first 2 hours. Why do you think they die within the first 2 hours? Why is that a statistic they felt they had to put up there? Because denial. A lot of people who have a heart attack don't want to admit it. Okay? And so they don't seek treatment until probably it's too late. Okay? And the longer you wait, the more heart muscle dies. You're going to see a big push when you start making your ride-outs, when you start doing your clinicals. You're going to see a big push for something called cath lab activation. And what that basically means is when we recognize out in the field that somebody's having a heart attack, we want to call the hospital and tell them to activate a cath lab. And what it means is all heart attacks don't happen between the hours of 8 and 5 o'clock. It just ain't going to happen. So after 5 o'clock, what do you think happens to the folks in the cath lab? They go home. And some of them live in Moody, in Salado. So what we want to do is, if I recognize that there's a cardiac event going in the field, somebody's having a heart attack, I want to tell the hospital, and generally what they want to see is what's known as a 12 lead. And if I have confirmation on 12 lead that I've got something called a STEMI, which stands for ST elevation MI, okay, they want to know that they're going to activate the cath lab, have all these people come in, as opposed to we get this person to the hospital 20 minutes from the time of call. They recognize it's a STEMI, then they make the call. So what's just been lost? Those 20 minutes, okay? So now that person only has to wait 10 minutes. They go to the cath lab. They get whatever procedure's got to get done. They open up those blood vessels. And what do you think happens to the percentage, or what I call the size of the heart attack? You think we can make it less? Well, I can't, but they can in the cath lab. Absolutely. This is kind of what we're talking about here. It says acute coronary syndromes. You're going to start seeing a lot more of this, okay? You're going to see this where, you know, actually it was pretty cool. Our medical director, Dr. McGraw, did a class on reading 12 leads to the whole department the other day. And she included all the EMTs, and the EMTs were coming out where they were capable of reading 12 leads. I thought that was pretty cool, okay? So we feel it's that important, okay? And see, that's what they're talking about. You have something called a non-STEMI elevation or an ST elevation, the STEMI, okay? Again, you'll see a lot of this as we go through. Now, the other two conditions we're going to talk about, these two guys, this guy right up here sitting by itself is a heart attack. These guys right here look like heart attacks. They look just like a heart attack. In fact, it's very hard to tell the difference between those bottom two and the top one. So the answer, question you're probably asking is, well, if it's that hard, what should I do? And this is a take-home lesson. What should you do? If you have one of these two conditions and you're not sure if it could be this, what should you treat it as? As this. Why? Because we get excited, we call the cath lab, and if we happen to have a person that's got unstable angina, that's okay. Okay, let's talk about some cardiovascular risk factors, okay? This category, and you'll see this stuff on your quiz, okay? The first category is what they call major uncontrollable, things that are real big and we can't do anything about that. In general, you're going to see things like age and sex, let me get them to pop up, race and hereditary issues. So again, the older we get, the more likely we may have some kind of cardiovascular disease. And why is that? What are some of the things that contribute to the age factor? Well, the fact that that older person is still not changed their eating habits. They've developed diabetes. They've developed hypertension. They're still smoking. They don't exercise. So those are the things that we're talking about there. Again, sex, not the act itself, but males and females. Who has more heart attacks, males or females? Actually, it's kind of a 50-50 split now. It used to be there's a differentiation, and really it's kind of hard to tell now. And generally, what you start to see is it's kind of related to age. Men will probably start to have them at a higher average at a younger age than females, but at some point females catch up to men, and we're about the same. Okay? Now let me ask you a question. Do men and women present the same symptomatically when they're having a heart attack?
No.
They actually will behave much differently, and we'll talk about some of those things. What race do you think is more likely to develop a cardiovascular disease? Black Americans. Okay? It's not to say that other races don't get it. It's just a higher percentage there. Okay? And hereditary issues. Okay? Again, if it's kind of interesting. I was teaching a CPR class once. The guy came up to me and said, "Hey, you know, I got a question." I said, "What's up?" He goes, "Well, what do you think I should do?" I said, "About what?" He goes, "Well, my grandpa died at 36 from a heart attack. My dad died at 34 from a heart attack. The next question came out of my mouth is, how old are you?" You might want to get your affairs in order, okay? Because some of that stuff is just passed down the tree there. Okay, so these are major controllable. These are, again, big things that we can control. And so again, if you smoke, hey, everybody's been warned about the effects of smoking. You can either choose to do something about it or you can't. And a lot of people say, well, it's difficult. Yeah, everything's hard. Once you get a habit, it's hard to kick that habit. But again, you weigh the options. Is my health worth this habit that I have? High blood pressure. Now, how are you going to control high blood pressure? Well, for a lot of people, it's just recognizing you have it and be willing to get it treated. I had hypertension for 2 years, and I said, I'm not going to mess with it, and finally got on meds and got my high blood pressure under control. So again, there's a lot of stubbornness out there. High blood cholesterol. Do any of y'all get y'all's cholesterol levels checked on a routine basis? Some of us do, but generally I get no to that question because most of you are pretty young and you just don't generally worry about it. But it's probably something you should get checked when you have a physical. Get it checked, find out what your levels are, and then respond appropriately to that. And then again, diabetes. People that have diabetes probably, you know, diabetes affects us in many, many ways, okay? And the way we treat diabetes is based on that individual. Some patients that have diabetes, the only treatment for them is insulin. Some of them, if they're in the early stages of diabetes, you know, maybe they get away with maybe just diet and exercise. Others, it's oral medications. Okay, minor controllable obesity. If that's an issue for the individual, they should work on that. Okay, lack of exercise. Generally, those two are tied in together. If you can, you know, develop a desire to exercise, you can probably target the obesity. Stress. Stress is huge. I think stress should actually go into the major category because way too many people have stress and they have no idea how to deal with it. And then personality. Okay, you think personality affects your stress levels? Yeah, that's kind of what drives it. Okay, so the bottom line here is if you can control the risk factors, you can decrease in coronary artery disease and the chance of developing a heart attack. It just kind of makes sense. So again, if you were to go back to all those things we just talked about, and somebody's a black American and they're overweight, they have diabetes, they smoke, you see where I'm going with this? You add all those factors to it, what is the likelihood that they're going to die from a heart attack? Well, according to all these things that are listed there, it's pretty high. Okay, and we all know that the heart muscle itself requires continuous nutrients to feed it, oxygen, glucose, nutrients, and if it doesn't get that, then it's not going to work very effectively. Toward the end of this lecture, we'll talk about what happens when the heart itself fails. Well, we can go into something called congestive heart failure, and then we see other markers we look at. Okay? We talked about that. The blood flow, what feeds the heart muscle itself, which I tried to tell you the other night, is those coronary arteries. And the first blood vessels that feed off the aorta are the coronary arteries. You guys remember them? There should be a right heart, so that's the right coronary artery. the left coronary artery, and then anterior descending branch, and then there's one that wraps around from front to back called the circumflex. So those are the major arteries that feed the heart itself. Okay, first word is atherosclerosis, and the definition of that, just a very basic definition, is we're looking at an artery, because it's athero, okay? So we're talking about an artery, and we're talking about the narrowing of the lumen, which the inner diameter of that blood vessel, okay? So what is it that causes a narrowing of that blood vessel? Probably plaque. And where does plaque come from? Your diet, what you eat, absolutely, okay? Okay, and your plaque formation is, again, is related to all those other things we talked about. Smoking. What does smoking do? You know how people go outside on a smoke break when it's cold in the wintertime and they go out and they smoke a cigarette and they go, this is going to make me warm? It actually reverses it because it's a vasoconstrictor. And so you actually, your blood vessels get smaller and you're actually sending less blood flow to it and you actually get a little bit colder. So really, it seems like I got a little fire stick in my hand, it's going to make me warmer. It has just the opposite effect, okay? Okay, so it results in decreased myocardial perfusion. That makes sense, doesn't it? If the blood vessel is smaller, then the blood flow going through it is decreased. So the muscle itself is going to be under what I call underperfused. What does perfused mean? Yeah, I'm getting oxygen from point A to point B, and when I send oxygen through it, I'm also sending oxygen and nutrients and stuff like that. So I'm feeding the muscle. So poor tissue perfusion causes things like tissue damage. I told you this a while ago, ischemia. Ischemia, again, is tissue damage, but not tissue death. What's the word for tissue death? Well, it's coming up. It's infarction. Okay? Can somebody have a heart attack and have ischemia? Absolutely. That's our target, guys. What we're trying to do is identify somebody that's having a heart attack out in the field, activate the cath lab, get them upstairs, and they do whatever they got to do, whether it's clot busters or they put in a stent, they open up those blood vessels again, okay? You and I, oxygen, aspirin, nitro, morphine, all that cool stuff that we give out in the field to stabilize them until we can get them to the cath lab. That's really important. And this is just a cutaway looking down coronary blood vessels. And I guess, you know, if you look at the blood vessel on my far right over there, that looks like just a brand new blood vessel. It's clean. There's no plaque formation in there. So that's just, it's just open. There's not going to be any issues with blood flowing through that. The only thing that's really going to cause an issue here if this blood vessel gets torn or damaged. As long as there's a good pump and that's the inside diameter, things are going to flow freely. But all this is trying to illustrate is what? Okay, maybe a 22-year-old, well, that could happen. You know, maybe a 40-year-old, maybe a 55-year-old person that smokes and obese and stressed and blah, blah, blah. And so this person, is he going to get the same blood flow to the heart muscle as this person? Okay, so let me kind of walk you through this. Let's say this person is obese, they're diabetic, they have hypertension, they're stressed out, and so they get outside and they start mowing their grass and it's 100 degrees like today. And all of a sudden they start having some chest pain. Okay? Are they feeding their heart muscle? Not very well. That's why they're having chest pain, okay? And so if I were to take a picture of their blood vessels, this is what I might see. So this guy calls 911. You guys show up. And in the back of your mind, you're thinking, if I could look at his blood vessels, I bet I'd see something like this. So you come in and you give him oxygen, you do a good assessment, a sample, an OPQRST, and all that kind of stuff. And you go, I'm going to give you some aspirin. So why are you going to give them aspirin?
So the platelets won't stick.
Exactly, because you know that this is a small opening, and you know the body's releasing what? Platelets. And platelets, by definition, what their journey and mission in life is to stick to one another, right? And to stick to a roadblock anyway. So as they start coming through here, what are they going to do? They're going to make the opening even smaller. So you give them aspirin, that way when the platelets go through, they don't do what? They don't make it worse. And then you guys decide, well, their blood pressure is 160 over 100, so let me give them some nitro. And what are you doing when you give them nitro? You're making the whole blood vessel larger, okay? And when you do that, that opening becomes a little bit bigger and blood flow gets through. So you're helping that person by all the stuff you did. You got them to relax. You got them in a cool place, okay? You call for 911, ALS intercept. Do you think when ALS gets there and they're going to slap a 12 lead on them, they go, hey, this guy's got a STEMI. And so you should be getting on the phone saying what? Do you want me to call and activate the cath lab for you? Does that make sense, how we all kind of work together? And if we get this person to the hospital, we can actually kind of make that a non-infarction event and make it an ischemic event. Okay? Back in the old days when people had a heart attack, you just dealt with it. It just did the damage it did. It just kind of ran its course. The doctor said, just lay in bed and we'll just see how bad it gets. That's what they did. Nowadays, we're very aggressive with it. We understand people need to have good, meaningful lives, and so we're getting really aggressive in how we manage people that we think are having heart attacks. Okay. Okay, angina pectoris. Now this is the first heart attack, but this is you can call all these heart attacks if you like, because they all look like a heart attack. It's hard for us to distinguish between the two. A while ago we said AMI, acute myocardial infarction, something different. Now we're shifting gears. We're talking about something called angina pectoris, which is kind of a Latin thing for, it's a choking in the chest. Okay, in other words, they feel like they're smothering inside their chest. Oftentimes, that's the description they'll give you. I can't breathe, I'm smothering. It feels like a big weight on my chest. Feels like a constriction feeling around my chest. Things like that, okay? Okay, and so this might be a typical presentation. This individual says, I've got this pressure, okay? And in this example, what we're showing you is that the pain looks like it started in this region, substernal area, and it kind of radiated across the chest, and it started going down the inner aspect of the arm right there. Now again, could this pain do pretty much anything it wants to do? Yeah, I could actually put this shaded area anywhere on this person, and I might think, or I would try to rule out an MI, angina, okay? So what I'm telling you guys is this. You might have a presentation one day that's a woman says, I can't breathe, and they're sweating profusely, and that's all they say. I don't have any pain, I don't have any pressure, I don't have anything. So please understand that all heart attacks do not look alike. Okay? In fact, many of them, very rarely do they all fit all the signs and symptoms you're looking for. Okay. So in this case, this guy was the one we just talked about. He went out back because his wife said, you need to mow the grass. And so he got out there 3 o'clock in the afternoon, decided to mow the yard. And so he had a blood vessel that had a 75% occlusion. His heart couldn't keep up with it. Okay, and so his body started doing what? His body started trying to warn him. It started giving him signs and symptoms. Hey dude, I'm going to give you some pressure. I'm going to give you some difficulty in breathing. I'm going to give you some nausea. I'm going to make you sweat profusely. I'm trying to tell you that you're having a heart attack. And if you don't recognize these signs and symptoms, I'll get bad enough that I'll just make you go unconscious. Okay? Body's really cool when it tries to tell you that things are happening. It's up to us to do what? To heed warning, okay? Okay, so it kind of stands to reason. That guy that we just saw, that scenario we just gave you, why didn't he have a heart attack at work?
At work?
Yeah.
Because he wasn't doing anything stressful.
Could he have a heart attack at work? Yeah, that stress could drive it, but in this case, it was the extra added stress of mowing the grass combined with the obesity and the smoking and the diabetes and the hypertension, and whammo, I hit you with this really high level of physical exertion, and so that's what happened there, okay? So when the myocardium is under stress, it's going to ask for more oxygen. And how is it going to get that oxygen? Through those coronary arteries. And again, if that coronary artery has a 60% occlusion, that's just one of them. What about if the other one has an 80% occlusion? And let's say the other one has a 90% occlusion. You see where I'm going with this? So the left has 70 and the right has 80 and the anterior descending branch has a high percentage too. Okay? Okay. So when they have angina, it's kind of difficult for them to dilate sufficiently. So what do you think they might do before you get there? Do you think he's got enough sense to stop mowing and get under the patio and get a cold glass of water and blah, 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 blah? And his wife recognizes something's going on. Okay. Let me ask you this. Let's say this guy had this happen to him 6 months ago. The doctor says, you have angina, and I'm going to send you home with nitro. Cool. So this guy knows he has angina, so he went home with nitro. So what do you think he's going to do before you get there?
Nitro.
Hopefully he's going to take his nitro. Okay? Now, how do you know that his nitro was good when you get there? You're going to ask him about what are the side effects that nitro might produce, which are, you said, tingling, burning under the tongue, a headache, maybe a lowering in the blood pressure, and maybe a decrease in level of pain. Okay. All right, some classic presentations. Again, chest, and I hate the word pain. They can certainly have pain, but do they have to have pain?
No.
So probably a better word, if you would, for me, just to make me feel better about it, in parentheses next to chest pain, just put chest discomfort. Okay, something different than just pain. SOB, again, is not their brother-in-law. It's shortness of breath, right? All right. And diaphoresis is profuse sweating. Very good. Profuse sweating. Then, of course, NV is nausea and vomiting. These are some of the classic things you might see. Now, again, I'm warning you right up front. Do they have to have all of these to be having a heart attack? Do they have to have any of these associated with the discomfort in their chest to be having a heart attack? No. You're probably going, dude, I'm frustrated because how do I know they're having a heart attack? My response to you is, treat them like they're having one until we find out they're not having one. And you cover your bases. There you go. Not all patients read the textbook. Some of them do. We have our classic people that want to ride to the hospital, and they've read the literature, and they just want to ride to the hospital. And they will textbook you to death. They'll give you exactly all the signs and symptoms of a heart attack. You do a 12 lead on them, they're not having a heart attack. But let me ask you this. I think I mentioned it the other day. Does somebody have to have an ugly 12 lead to be having a heart attack? Can somebody have a beautiful, perfect 12 lead and still be having a heart attack? The answer is yes. All right, so some of the symptoms, some of the things they might tell you again are they have pain and or discomfort. Substernal meaning this is the sternum, right? And sub means like a submarine, so below. So underneath the sternum, and often I also want you to add something called epigastric. Epigastric, which is right on top of the belly, right here, just below the sternum, epigastric. So let me ask you this. You get there and the guy says, well, I just had a lot of greasy food and I came back an hour later and I felt like I had indigestion and I took some antacid and that really didn't help any. and I started sweating, I get nauseous, and now I have some aching sensation in my shoulder. Hey, is it indigestion or could it be a heart attack? There you go. And these are just some descriptors. Be careful. We very often will try and give them the answers that we want to hear. We'll say all this stuff and go, yeah, I got one of those. Which one do you have? Well, everything you just said. Okay. And as we mentioned, this discomfort could radiate into multiple locations. And just to try to sell my point, if I can, years ago I picked up an elderly gentleman out in the country, and he was country strong, never been to the hospital a day in his life, very healthy old man. And so he called us because he said he started having some pain right here in his elbow right here. And so he'd been mowing his grass and he's starting his lawnmower and it's real hard to start. So he goes, I think I hurt something in my elbow when I pulled the thing. And so the first thing that's unusual is what? Why the hell are you calling me for arm pain? You know what I'm saying? If he's never gone to the hospital a day in his life, why would you call me for arm pain? Yeah, he's trying to tell me something, but he's not wanting to admit it. But this is the only pain he complained of. So we went ahead, he fit the profile, we went ahead and put him on the monitor, and there was something that's a little funny on that EKG, and so we treated him. We treated him like he was having, some problems. Get him to the hospital. En route to the hospital, when we get to the hospital, we say, how are you feeling now? He goes, I feel great. He says, I'm really embarrassed I called you guys. So we're outside doing our paperwork, and one of the nurses walks out. She goes, hey, you guys want to come in and help us? We're working CPR. And we're going, sure. We love working CPRs. So we walked in to help them with his CPR case. Who do you think it was? This guy right here with the pain right there. So that was freaky, wasn't it? Doesn't fit your classic presentation. What I'm telling you guys is just be mindful that certain age groups, when they start saying something's abnormal and they can't put their finger on it, I can't either. But I'm probably thinking it's cardiac until we can rule it out. Okay? Also, it could be associated with shortness of breath, nausea, and in some cases, the ones that I have walk in and they're just saturated with sweat, I'm thinking two things. If I see somebody that's just broken out in a heavy sweat, one of two things is probably happening to you. One is you're having a heart attack, or the other one is you're in insulin shock and you're hypoglycemic. So note to self, if you see somebody it's really sweating, they're not outside doing physical exertion, you need to think one of those two things is happening. But it could also be associated with other things. You see what I'm saying? But that's just something that I've seen in my practice. All right, the pain is associated with the three E's. It's probably exercise, emotion, and eating. There you go. And if you would, just for S and G's for me, if you'll write a fourth one down there, the fourth E is environmental. Environmental. So let's go through these very quickly. So what I'm telling you is that the act of eating can cause you to have a heart attack. Is that true? Mm-hmm. How?
Adding more fatness and food.
What's that? No, I'm open. I'm not making fun of anybody. What is it about eating that makes me have a heart attack?
I think it's probably the physical exertion, too much fried chicken.
Yeah. Have you seen some people eat? That's work. That's one of them. What's the other one, though? Biggie.
What they're eating.
Another one.
Like if it's stripping place or something.
Overeating?
Probably. Remember, the heart requires a certain percentage of blood flow. And when you eat and you're starting to break down a huge meal, you're actually sending more blood flow to the digestive system, to the GI system. So you're actually taking blood away from where?
The heart.
All parts of the body and some from the heart, and maybe just a small deficit, just a small percentage of blood that you're taking away from the coronary and sending it to the GI system for the breaking down food, that may be enough to do what? To cause me to have a heart attack, okay? So eating can certainly be one. Everybody agree with emotion? If we get in stressful situations, what happens there? Well, your body starts dumping epinephrine and your heart rate does what? Does it increase or decrease? Yeah, it jacks up. So does your respiratory rate, okay? The other one was exercise. Again, people who are overexerting themselves. And exercise could be I'm mowing the grass, I'm running, you know, huge race, whatever. Now, why do you think we put environmental up there? How can that cause a heart attack? Exactly, too hot or too cold. So if you're in an environment that's too hot, is that going to stress the heart? Mm-hmm. If you're in an environment that's too cold, could that stress the heart? Absolutely. All right, this is kind of what's cool. Just listen to me for a second. If I were to ask somebody to go to the dry erase board and write down the signs and symptoms of an AMI, you'd make a list of them. Now, if I were to ask somebody else to write down the signs and symptoms of angina pectoris, you'd write them down in a separate column. Do you think they would look very similar?
Yeah.
Exactly. Both of them, you would actually put the same signs and symptoms for each one of those conditions. So you're probably asking me, is how do I know the difference between somebody having a heart attack or somebody that's just in angina pectoris? The answer is what? It's actually looking at you on the slide.
Time.
Exactly. So with angina, what we're saying to you guys with angina is that pain seldom lasts longer than 30 minutes, and it generally goes away with things like rest, nitro if they take it, and then you guys get there and you give them oxygen. So those are the things that probably relieve the pain of angina. Okay? And these are just some of the things that these people may feel. So are you going to have to be a coach? Sure, they're going to be scared. Why do you think they waited 2 hours to call you anyway? Why don't people call you within the first 2 hours?
Denial.
Well, what's the big deal? I don't understand.
Pride. Bill.
Shame.
What's that?
There's shame.
And?
Afraid to ask for help.
Right, and what else?
Money.
Maybe. What else?
They're uneducated.
Pride.
There's a good one.
What was it?
Uneducated. What's the other one?
Pride.
Pride. Absolutely. Kind of where I was going with that is a control. If I'm having a heart attack, what have I just lost?
Control.
I've lost control. And I'm usually in control. And when I lose control, that's not a good thing. Okay? Okay. And we understand this fixation of the body. They don't like to move. They stare off into space. They have this look about them. They may have a discoloration, pale, ashen, okay? And livid faces. They've kind of got a blank look to them, okay? And then dyspnea, we talked about that, just shortness of breath. Okay, nausea, diaphoresis, everybody understands those two. We don't have to go over that. This one, it says blood pressure is usually up during the attack. Can anybody tell me why? Why does the blood pressure go up during the heart attack initially? And why is it working faster?
Blood stress.
Because what?
It's stress. Trying to pump more blood.
But what chemically has just happened? What did we just release in the body to make it that happen? Adrenaline. Exactly. So when you release adrenaline in the body, it's going to tell the heart to do what? Beat faster. And when it beats faster, what's it going to do to the blood pressure? It's probably going to bump it up a little bit. Now, is it going to stay there? It may not. Once that adrenaline burns off, or once we start giving nitro, it's going to come down. All right, dysrhythmia may be present. Now, how do you or I know as a basic EMT that there's a dysrhythmia? The first question is, what the hell is a dysrhythmia? Well, rhythm means if I were to take a picture of the heart would create a certain rhythm. So this is a different, funky looking rhythm. So it's going to have something other than a normal, what we call normal sinus rhythm. So you're going to have an abnormal heart rhythm. And if I were to put them on an EKG, and I were looking for these spikes, and I was looking for the spices and the spaces and all this kind of caca, and it just looks different, I'm going, man, I don't read EKGs, but I can tell you right now, that don't look right. Now, how do you guys know, without that EKG, that they have a dysrhythmia?
Your regular pulse.
Absolutely. And that's why I tell you it's really important to feel a pulse and tell me, is it regular or irregular? If the heart is beating without any problems, it's probably going to beat at regular intervals. Now, 2 questions, I think. You have questions?
I'm just going to answer the pulse question.
Oh, I'm sorry. I got a fat mouth and I keep talking. Maybe I'll just shut up about it. Shut up when you're talking to me. All right. All right. Following an angina attack, there is no residual damage to the myocardium. So what we're saying to you is angina is what? Is not a heart attack. But does it look like a heart attack? Absolutely. So this is just signs and symptoms. What does angina sound like to you?
Indigestion.
Huh?
Indigestion.
Kind of, yeah. But what else does it sound like to you? I want you to think a little globally. Angina is a baby heart attack. It's like one of your offsprings. It wants to grow up to be just like you. Okay, so angina is what?
Small heart.
Mom and daddy is AMI. Angina is the beginning of it. So angina eventually wants to be what? An AMI. And it will get there with what? Time and all them buckets of chicken you eat and more plaque you put in and more smoking and all that crap. Eventually, hey, I'm going to turn into an AMI. Okay?
It's basically a warning.
Exactly. That's why I tell people, you know, if you have that warning, you need to go get it checked out. Go get you, all the tests done and get you an angiogram, get a picture taken of your heart. But you can't just say, hey, doc, I need this done. You have to have a certain presentation before they actually do that. All right, so let's talk about the forms of angina. And the first one is what we call stable angina. Now, it says that it is probably predictable. It occurs with exercise. So again, if I overexert myself, I know what? I'm going to have a decrease in blood flow, which is going to cause what? Nausea, vomiting, shortness of breath, sweating, and maybe some pressure in my chest. I know this is going to happen. So I know if I go in my room and I take some nitro, that pain is probably going to go away. And it went away because what? I took the nitro and it did what to the blood vessels? There you go. Y'all feel like y'all are learning some stuff already? Okay. Because y'all look like you are. All right. It's predictable. All right. We know what's going to causes it to happen. And we know what the outcome is going to be if we do it in a timely fashion. Okay? And again, we talked about the relief comes with rest and nitroglycerin. All right, unstable angina is just a little different from that. It's not so predictable. Okay? And it's probably going to come at more frequent, it's going to have more frequent attacks, and they're going to be a little bit more severe. Okay? This thing is friggin' slow. Can occur during rest and may indicate an impending MI. Now, a while ago I just made this thing about I'm baby and you're daddy and daddy is an AMI and I'm just a little angina kind of thing. When I go from stable angina to unstable angina, I know the next step is what? AMI. Now, I want you to tell me physiologically in the heart what's happening. Why am I going from stable angina to an to unstable and an AMI, what's happening?
Muscles are dying.
No.
Enough
The
blood.
muscles are dying, but the vessels are becoming more narrow.
Thank you. That's perfect answer. That's exactly what I'm looking for. This guy was sitting on a what? 40% occlusion. 2 years later, he's starting to have episodes of unstable angina, and that 40% occlusion went to what? 80% occlusion. Okay? And then next year, he didn't change any of his habits. In fact, he started smoking an extra pack of cigarettes a day. And he's out mowing his grass, and he has a big one. So if they do the bypass and all this kind of crap, and they find out that he had 99% blockage. Does that make sense to you guys? So physiologically what's happening with time, if you don't change those factors, your cholesterol levels, your smoking, your eating, your fat ass, all that kind of stuff, you don't change that, what happens? You're going to have the heart attack. There you go. All right. Now, what does it mean to transport him to the appropriate facility? I thought all hospitals were appropriate facilities.
Some hospitals don't have cath labs or surgery.
There you go. So let me ask you this then. You guys met my wife the other day. She gets a call because somebody in Holland's having signs and symptoms of a heart attack. And the EMS service out there drove all the way out there. They did a 12 lead, and they said, this guy is positive for ST changes. So they go, well, we could haul ass in a Temple, or we could call a helicopter. As soon as we got that chest pain call, we both get there about the same time. So they fly them in, direct line of sight, 160, 80 miles an hour. So they get here a lot faster. We've already activated the cath lab. Have we done the patient some good? So that's kind of how that whole system should work. And you know the worst thing that can happen here is people have these freaking huge egos. And they go, no, I got this. I can handle a heart attack. Well, yeah, you can handle it, but at the expense of who? At the patient, because the patient's sitting there while you're dicking around, you know, playing doctor, and the more heart muscle is dying. Thank you very much. You just kind of shot some of my heart muscle. I appreciate that. All right. And we know what that is. Inadequate perfusion of the myocardium, which causes death of the myocardium. Okay. And we know that you can have two forms, infarction and or ischemia. Okay, now these next slides that we're talking about AMI, do you think they're going to look very similar to what we just talked about?
Yeah.
Yeah, you could probably read them and tell me what they are. Same crap, isn't it? Same stuff. So I'm just going to go fast because we already know what it is. Because you got this, right? Okay. So sometimes we threw something different up here. It says unaffected by swallowing. Oftentimes people have a discomfort in their chest, and it's actually made worse by certain things they do, like taking a deep breath. That's called pleuritic chest pain. If my chest pain is made worse by taking a deep breath, is that probably cardiac in nature? Probably not. If I twist like this and I pull the muscle in my chest, ooh, every time I do that, that hurts. Is that cardiac in nature? Probably not. If I assess you because you're telling me you're having chest pain, and I get over there and I mash on your chest, and I said, tell me if that makes it worse or better. So if I mash on it and it makes it worse, is that probably cardiac in nature? But if it doesn't change that value of discomfort you feel, could it be cardiac? Absolutely. So I call that reproducible chest pain. In other words, mash on the chest. Don't thump them. Mash on the chest. Does that feel better or worse? Cough for me. Take a deep breath for me. Swallow. Does that make it better or worse? All right. Very good. All right. So what we're telling you guys is, hey, this guy just had this lawn mowing episode, and he took his nitro, and it had a burning tongue, and his blood pressure dropped, and his pain was 10 out of 10, and now you get there and his pain is still at 10 out of 10, and you do a 12 lead and it's positive for an ST elevation changes. This guy having a heart attack?
Yes.
Absolutely. Okay? So, again, what we're saying to you is that they start having and moving toward the direction of an AMI. One of the other differences here is what? That stuff that's supposed to relieve the pain isn't working. Okay? Okay, now we talk about a silent MI. A silent MI is a real quiet heart attack. What did I just say?
Silent MI is a really quiet heart attack.
Why is it so quiet? It wants to hide from you. Right? It's trying to hide from you. Why is it trying to hide from you? It doesn't want you to identify it as a heart attack. Why? And who do you think is going to be, who do you think is going to have a silent heart attack? Old people. Absolutely. Why do you think old people are going to have a silent MI? And again, a silent MI is atypical presentation. A means what? Absence of. Atypical presentation. So they have unnormal presentation, abnormal presentation. They're not going to have the nausea and the sweating and the crushing pain and blah, 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 that crap. They may not have any of that. Okay? So the two populations they're going to have atypical presentations are the elderly and the diabetics. Okay? Again, elderly is because their pain ability starts to decrease, their pain sensories, and diabetics because of something called diabetic neuropathy, meaning that high concentrations of sugar eventually will destroy nerve endings. And so diabetics, we're not going to have that pain that you expect to see. They're going to have that typical presentation you expect to see. And there you go, particularly common in elderly and diabetics. Let me see. I'm going to stop if we see anything new that we haven't talked about already. Everybody know why they're weak and dizzy and fainting? There's a decrease in blood flow, absolutely. And so I'm going to pass out. Remember I said God's going to try everything He can to get you to sit your ass down. Okay? And so everything changes. Sense of impending doom. What would you do if somebody looked at you and said to you, I'm going to die? Yeah, that's the typical reaction. It's a laugh. And what I'm telling you is if anybody ever tells you I'm going to die, you better get your ass ready. Because they are going to die. I've had way too many people tell me I'm going to die and proceeded to die. Absolutely. If they tell you I'm going to die, be careful. Because they have that sensation, they have that feeling. I don't know what you want to call it, but they know something's not right, and their plan is just got off axis, and something's about to go really bad. Okay? In denial. All right, and we talked about that. And what we're trying to say here is please don't look at vital signs, because as EMTs we look at something that's tangible that tells me you're having a heart attack. What I really want you to do, guys, is I want you to please be kind of broad in your thinking and go, okay, this guy is his age, he's a smoker, he's a drinker, okay, he was doing physical activity, he's never had a heart attack, he doesn't have any heart disease, but today, could he be having a heart attack? I think so. So, please don't just say, well, I'm going to confirm he's having a heart attack by checking his vital signs, because that'll surely tell me. Will it tell you?
Maybe.
No.
It may and it may not. But if he looks like he's the classic presentation of an AMI and his vitals are also altered, is that now a better fit? What I'm saying is don't say, I'm not going to believe you're having a heart attack until I look at your vital signs, because the vital signs really don't tell me anything. Okay?
But you still want to take their vital signs just to have a basis.
Oh yeah, you have to. Well, I'm just saying is don't look at them and go, don't ever look at somebody and go, oh, you can't be having a heart attack because your vital signs are way too damn good. They're actually better than mine. Really? So that's what I'm trying to tell you, okay? I was just trying to do it nicely a while ago. Okay, do you think it's important to recognize somebody could be having a heart attack early? Why?
Can't treat it medically.
The rule is time is muscle. The longer we wait, the more muscle we waste. The longer we wait, the more muscle we waste. Okay? And didn't we kind of allude to this a while ago? If you're not sure whether it's angina and it's stable or unstable and all that stuff, hey, I'm betting that you're probably having a heart attack. Now, are you going to tell them they're having a heart attack? No. But are you going to be working as though they were having a heart attack? Are you going to be working a heart attack protocol? Aspirin, nitro, 12-lead, cath lab activation, all that kind of stuff? Absolutely. And what you need to do is work covertly. You need to recognize all this, and at the same time, don't get them so excited that it makes it worse for them. You know what I'm saying? Okay. All right. And so again, the management's important. And please don't let anybody ever tell you that as EMTs we don't make a difference in any of this stuff, because you do. The first step is recognition. So let's say you guys show up and you recognize all this and you tell me all this. Dadgummit, you've already diagnosed this guy's having a heart attack, and actually you've given me some really good information. So I kind of like what you're telling me. I'm going to go with that. All right? All right, it says to complete your history and physical exam. Now, this is really important, and we'll spend a few minutes talking about this and give you a break. What, at a minimum, do I want you to take on this patient? I want you to take their vital signs, blood pressure, pulse, respirations. What else? Oxygen saturation. What else? Blood sugar. Okay, very good. Now, I want you to do some history. What history do I want you to ask? What's that word?
Sam.
Take a sample. Signs and symptoms, allergies, medications, past pertinent history, last oral intake, and
Last mention.
events leading up to it. Did I say medications? Okay. What other assessment questions do you need to ask? Oh my God, how important is that? This is probably the most important time you're ever going to pull the OPQRST out of your little bag of tricks. This is it. This is your time to shine. This is time you go, hey man, I just learned this OPQRST crap and I'm going to whip it out and I'm going to impress somebody. This is the time to do it, guys. Because think about it, if somebody's having a heart attack, let's go through it. Sir, ma'am, can you tell me if this happened all of a sudden or was it gradual? Yeah, I was just kind of doing nothing and it just hit me all of a sudden. So it's acute onset. Can you tell me what makes it worse? Well, I was doing a bunch of running, and every time I was doing exertion, it made it worse. There you go. Q, quality. Can you describe what it is you're feeling? Don't say, tell me something about your pain. Because they may say, I don't have pain. Just have this pressure. So describe what you're feeling. R is point to where it hurts. Well, it hurts right there. Well, does it move away from there? Yeah, it kind of moves across the chest. Radiation. Now, did you take anything before I got here to make it better? Yeah, I took a little nitro. How many did you take? 2. Did it help? No. Take your blood pressure. Okay, blood pressure is low. You've got a tingling sensation. You've got a headache. So nitro is good. Okay? On a scale of 0 to 10, how would you rate this level of discomfort you're feeling? About a 9 out of 10. Okay? And tell me total time. We got called about 15 minutes ago. When did these signs and symptoms occur? Well, about 15 minutes before that. So total time now is what? 30 minutes. We actually want these people in the cath lab as quickly as we can get them there. Less than 2 hours. Okay? So if, for example, they told you they started hurting an hour before they called you, okay? Took you 20 minutes to get there, so now we're sitting on an hour and 20 minutes. It's going to take us about 35 minutes to get back to the hospital because we're trying to get them to the appropriate facility. Now we're sitting on what? 2 hours just outside that window. So maybe now it's time I need to call a helicopter and I can get them there a little bit faster. Does that make sense? All right. So, man, you need to ask the OPQRST. That's the most important time to do that. Okay, I said I would give you a break, and I'm a man of my word, so we'll take a break. waterfall too.
Not been to them, so I'll answer your question. 3 or 4 times I've had it where I have pain right in here. You know, sometimes it's after working, exercise, and things like that. Sometimes it's when I wake up and it will stay for hours or so. I'll sit there and work my shoulder out. Talk to the doctor.
How old are you?
31.
Family history?
Mostly men on my mom's side have had heart disease, heart failures. My grandfather passed away from a heart attack. My uncle right now, he just got out of the hospital with a stroke.
There's a large in there.
So it's family history there.
What I mean, it's just tingling or numbness or pressure.
Just pressure pain. You know, kind of a. Sometimes it's just pressure, like somebody's pushing on my chest.
Do you have any other symptoms?
No.
I don't think it's cardiac. I think it's nerve endings that you probably feel. Go ahead and pull them out of the plastic bag. Yeah, pull them out. But I would probably talk to your doctor about it. But it doesn't sound like it's typical cardiac stuff, you know. Especially with it comes at different times and stuff like that.
I mean, there's, you know, in high school.
That's a huge shirt. That's large. You probably need a medium.
Yeah. No, there's 2 in here as well.
Yeah. So that one is. Which one are you looking at? The first one or the last one?
The first one's medium, this one's large.
Now those are different. Now you're going to have to take those paramedic patches off.
Oh, okay.
Okay, but that's probably all you have to do. Their shirts are different levels of condition, and some of them are better shape than others. Some of them are brand new. So I don't know, but I would talk to your doctor about it if that's that much of concern to you and stuff like that. But try it on. There's a dress. You can go in the other room and try it on.
You know, I've had pain in my shoulders and things like that in my right arm, but never in my left. And it was that's for 2 or 3 years.
Yeah.
I've gotten these. Like I said, it'll pretty much just hit me. It's like somebody punched me right here, and just kept pressing.
Yeah.
You know, and like I said, sometimes I'll sleep wrong, and but it stretches off in my back, and shoulder blade.
Doesn't sound typical, but again, you probably talk to him.
Okay.
I think I said just don't have cash on me, just on a card.
Well, just pay me when you can. This the one you want right here?
Yeah, probably. But I said they don't even matter.
That's $5 right there.
Mom's a tailor anyways.
Huh?
My mom's a tailor, so she can fix it.
This is yeah, that's fine. You want to try it on? Or you want to take your shirt off? Sexy boy. You go in the other room, try it on, man. Right here or the bathroom, don't matter. We're not going to peek. We're not peeking. We didn't have a size for you?
I'm an extra large. I got an 18-inch neck.
You extra large, you. We didn't have a big
I'm a
one.
big guy.
16, 16 and a half is going to be too small for you.
Yeah, exactly.
Well, you don't have to wear a tie with it, you know that.
No, I can tell you where I'm at. That fluctuates. Because right now I'm on the medication I'm on. When I go off,
They all look the same.
when this cycle runs out, I'm off it. I'll go back up. I'll put in the 15 pounds back up.
Are you on your low end or high end right now?
I'm on my bottom end.
Bottom end? Because these are cut bigger. Some of them are cut bigger than what their sizes are.
Because I'm on Topomax right now, and that takes.
Hello.
So when I go off of it, it'll go back. I'll put on another 15 pounds back on.
Are we recording? Yeah, we are. The little green thing's going on. Okay. We're talking about how to take care of people who have chest pain. Position of comfort. What does that mean, position of comfort? Exactly. Perfect. That's exactly. You find a position you're comfortable with, and I don't want you to be stressed out. For example, my protocol says you got to be laying flat with seat belts on, all this kind of crap, and it increases your level of anxiety. You know what? Screw the protocol. If you're happier sitting up, then guess what? You get to sit up today, okay? So find out what makes them comfortable. Now, is that a misspelled word?
Pattern
Huh?
airway?
That's exactly the word we use, patent airway, which means what? It's good, it's open, it's secure. Make sure they have a good airway, a good patent airway. Give them high concentration oxygen via some kind of mask device, okay? And there you go. It says a non-rebreather. Y'all talked about this in the oxygen stuff the other day, didn't y'all? Non-rebreather at 10 to 15 liters per minute. Says to reassure them, provide them with all the confidence, get a brief history and physical exam. Again, the things we're going to be doing is getting their vitals, a sample history, OPQRST, things like that. Aspirin at this dose is probably what we want to give them, 325 milligrams. Question, what about if you start giving them aspirin, they go, well, I've already had my aspirin today, I had to take it once a day. Oh, wait a minute, you're screwing up the works. You're not supposed to answer that. It's like kind of like come at with a knife. No, not like that, like this. But no, it's a joke. But what happens if they have already taken aspirin?
Ask how much
Ask
they
how long ago and what was the dosage.
You know, what we're routinely doing in pre-hospital now is we're giving them like 1 to 2. But for the test, please, this is the answer we're looking for, 325 milligrams. What I'm saying to you is be able to stick and move. And somebody says, I've already taken it, you go, crap.
How long
They didn't prepare us for that, you know? So, again, call med control. Look at your med partners. You're going to say, well, just give them 1 or 2. It's been long enough. We can give them another 1 or 2. I'm not going to bleed to death from it. And, again, we want to give nitro. We give nitro by what route? Sublingual is the only route. Please understand. Test question. Sublingual is the only route that you and I are going to assist with. Okay? That means underneath the tongue. And what form are we going to do that with?
Tablet.
Tablet and or
Spray.
spray. That's all we're going to do. Now, does nitro also come in a patch and a paste?
Yes.
Are we allowed to give it that way?
No.
Are we allowed to give it IV?
No.
Are we allowed to give it rectally?
No.
Okay, thank you. All right. Now, why do we want them sitting or lying?
Because of their blood pressure.
It could drop their blood pressure significantly. Absolutely. Now, again, that question you want to find out, have you taken nitro? Did it help? And is it working? And again, you know the value of nitro. You know whether or not it's good or not. And again, don't get wigged out if you say, have you taken nitro? And they say, yeah, I took about 5 of them. And you look at their blood pressure and it hasn't changed. They're still hypertensive. They have no headache. Should you be prepared to give them some of your nitro?
Yes.
Funny story. Back in the day, on this campus, at the gym over here, we used to have wrestling in town. Wrestling was a very popular sport here, and so we had wrestling matches that they had here. And I had all these medics working this event with me, and I was working one of the front doors, and an old man walked by me. He goes, he was panting. He goes, I made it. He goes, I only had to take 12 nitro to get here, but I'm here. Wow. Wrestling is very important to you if you had to take 12 nitro. And so I get on my covert little radio and tell everybody, hey, I got one over here we got to watch that I think he's going to go down at some point during this wrestling match, and he did. And I make the joke to other people. I said, we had so many friggin' paramedics there, he could have died if he would have wanted to. We weren't going to let him die. But he actually had a heart attack during the wrestling match. He was probably having a heart attack before he got there, in reality.
He probably got so excited watching the wrestling match.
Well, yeah. Now, this is a little confusing because the other number we used before was what, 100, right?
Yes.
So, I'm going to be more on the cautious side, and I'm going to use the higher number as opposed to the lower number, okay? And I think most of our protocols use like 100 systolic. Now, what does Q mean? Very good. So every 5 minutes until pain is relieved, or 3 tablets have been administered, or 3 sprays. Let me ask you a question. What happens if you give somebody a nitro and they go, and they chew it up, and you're going, oh my God, you weren't supposed to do that. Oh my God. You chewed the nitro. What happens?
Shake it up a little bit, see if they explode.
Yeah. The answer is nothing. It just takes a little longer for it to work. Now it's going down this direction. It has to break down. I'm going to wait 5 minutes and give one under here in the tongue again and say, don't chew this one up, okay? That's why spray's a little bit better, right? Because once you spray it, it's there, all right? All right, you want to transport them in a semi-sitting position and change their position if their blood pressure is low. If they're semi-sitting and they go, I'm really lightheaded, dude. Well, let's bring you down to a point where you're not so uncomfortable. That's probably a good idea. Don't walk them down from the 2nd story to the engine or to the ambulance, okay? That's probably not a good idea. And again, we're going to have those cases. We're going to have a 350-pound man upstairs, and we got to get him down. I'd love it if you could walk down, but I'm not going to make you do that, okay? So what are we going to do?
Call for additional help.
Yeah, you call for the additional resources. You get an engine company. You get an ambulance crew. And if you got a large person, you get a 2nd engine company. There was times when we would call 2 engine companies to haul a patient. It was a routine basis. We knew this. We had a 600-pounder. We had to move. Okay, so be able to stick and move. All right, what's the deal with the lights and sirens? Dr. McGraw would probably debate this point. You know, we want to get him to the hospital, but the point is, I think common sense has to prevail here, and what we're trying to say is, don't overexert him, don't overexcite him. Okay, but again, you're already having a heart attack, but I really need to get you to the hospital 5 minutes earlier, and if I can do that running code 3, I'm going to do that. But if their knuckles are turning white hanging onto the stretcher, you know, you're probably not doing them any good. So some common sense has to come in at some point here. And again, you want to get their vitals every 5 to 10 minutes, check for signs of changes, trends, things like that. It says to request an early ALS backup as quickly as possible. They could die from arrhythmias, things like that. And again, the reason we call for the early ALS intercept or whatever is because there's certain drugs they can give to stabilize certain arrhythmias or dysrhythmias. All right, hypertension, again, is a big fancy word for high blood pressure. Do you think high blood pressure is a bad thing? It sure is, okay? The condition can be chronic. In other words, a person has a history of it. They're usually under medication for it. And oftentimes, you know, they change the regimen of their medication. They change their dose, things like that. And all medications, all hypertensive meds don't act the same way. There are some drugs that cause you to pee. There are some drugs that are really hard on the kidneys. So if you've got, you know, gentle, fragile kidneys, they're going to give you a different agent. Okay, there's, I mean, again, there's just a whole host of different hypertensive medications. All right, the pathophys is you need to understand what is hypertension. You know it's something that's greater than 120/80 or 150/90, but what is hypertension? Why does that person have hypertension? Well, if you think of it this way, there's a blood vessel. There's the ventricle. And hypertension, or your blood pressure, basically is how much pressure is generated, how much that ventricle has to contract just to get blood to flow. That makes sense? Mm-hmm. So, if I've got an open blood vessel, there's no resistance. I don't have to push against anything. You follow me? But if I got a lot of blockage, in a lot of different areas, and I'm trying to get that same amount of blood flow through there, I'm having to really squeeze hard. Okay, the harder I squeeze, the higher the blood pressure. So hypertension is the amount of pressure, or blood pressure is the amount of pressure it takes to get blood from point A to point B. Does that make sense? So what causes us to be hypertensive? Generally, we've got blockages, and we have plaque, and we have other problems going on. Okay? So it's an increased pressure to the organs. We have a huge pressure going through there, and the pressure is usually constant, and it's affecting other organs. Okay? We have decreased blood flow and increased afterload. In other words, how much pressure we have to push to get out. Preload is how much pressure we have to get blood to the heart. Afterload is how much we have to do to get it out of the heart. That's those two measurements. All right, congestive heart failure. You need to know this stuff right here. We actually say congestive heart failure, but we use the abbreviation CHF, which stands for congestive heart failure. And what that basically is the inability of the heart to pump blood out as fast as it enters. So this is a pump, and every pump has what? An innie and an outie. You know that? In other words, something comes in, and it's got to get pumped out. So an innie and an outie. So that means that in a pump, flow is designed to go what? One direction. Now, if that pump fails, what do you think is going to happen? Well, it could go the opposite direction. Okay? So again, a pump that's working correctly brings it in one direction and sends it out a different direction. Now, there are three types of congestive heart failure. So all we're saying here is when we say left-sided heart failure, that actually means that the patient's left heart has failed. If they have right-sided heart failure, the right side has failed. If they've got both sides failing, we call it complete heart failure. Can people live in right or left or complete? The answer is yes. Okay? Now, do they generally do as well as you or I?
No.
Probably not. Because I got a good heart and you got a sick heart. So you're not going to do as well as I am. Okay, so what causes congestive heart failure? Congestive heart failure could be caused from coronary artery disease. It could be caused from chronic hypertension. It could be caused from probably a heart attack and valvular heart disease. What does valvular heart disease mean? How many valves in the heart? 4. So one of the valves is what? Not working well. And probably the problem could be that what's really cool is these hearts have little leaflets, and they have these papillary muscles and chordae tendineae, and what brings them down, and they close like this. It's kind of cool. What can happen sometimes is something called stenosis. In other words, plaque develops around the vessel or the valve itself. What could also happen is the little muscle fibers that open that cusp and close it, sometimes they wear out. What can happen sometimes is somebody can develop something called enlarged heart syndrome, where their heart grows bigger this way, and when it does, it stretches those, and there's a little space where those cusps used to make contact. Now it stretches them out a little bit. So blood does what? It backflows. Okay?
I got a question. What is a heart murmur?
Heart murmur is blood, a valve that's not working 100%, and blood goes the opposite direction. Now, most people, if you have a little bit of blood going the opposite direction, not that big a deal. But generally, heart murmurs are something a doctor will watch, and they'll say, well, maybe you'll outgrow it, or maybe at some point in your life, we're going to have to look at that valve, and we may have to replace it. Okay? Now when they go and replace a valve, there's two ways they can do it. They can put in a pig valve, a bovine, or they can actually put in an artificial valve. Okay? Now the difference between those is they put in an artificial valve, you have to be put on, since it's artificial, they have to put you on what's called Coumadin the rest of your life. That totally sucks. If you can avoid ever getting on Coumadin, you're really good. Okay? But Coumadin is something they have to balance the weight of your blood, the viscosity of it, and it's hard to do because things like stress and diet and all that kind of crap change that. But if you're on a natural valve like a pig or a cow or something like that, then you don't have to be on Coumadin. So if you ever have to have a valve, here's the other part of it though. Artificial valve is generally good for a lifetime. Pig valve is generally good for about 15 years. If you outlive it, then you have to have another one. So
Wouldn't you have to be on immunosuppressants for that too? So your body wouldn't kill the bacteria?
the auto-rejectant, there's certain things you're going to be put on, but you know, and I don't know all of them, but that could be one of them. All right, it says that congestive heart failure usually begins with the left side. Okay? And generally it's because the most common area of infarction is going to be the left ventricle. Okay? So what we're saying is most heart attacks occur to the left ventricle. Therefore, people are more likely to develop left-sided heart failure. And this is, it can be really complicated, but I'm going to try and make it really simple. But it's actually would make a lot more sense to you if you understood blood flow through the heart itself. But this is a very simple way of looking at it. Remember, when blood comes from my lungs, it's been oxygenated. It comes to my left heart, right? It comes into my left atrium. Then it goes to that valve, which is what?
Bicuspid.
Mitral, right? Bicuspid. And then it goes into the left what?
Ventricle.
Ventricle. Very good. From the ventricle is going to pump it into the aorta, but it's got to go through what?
Aortic.
The aortic valve, and then eventually into the aorta. Well, roger that. Here we go. Well, what this is saying is left-sided heart failure, so it's saying the left ventricle is failing. You with me? So what does the left ventricle do? When it contracts, it sends blood to where?
The body.
To the aorta and to the body. You with me? Okay. So if the left ventricle fails, what we have to do is we have to take blood and go the reverse direction. You with me? So if it's in the ventricle, we got to go backwards. So the ventricle, it went through what? That valve into what? Left atrium. and from left atrium it's going where? To the pulmonary blood vessel. To what?
Lungs.
There you go. It's going back to the lungs. So what we're doing is we're sending more blood back to the lungs. It's going to seep out the capillaries into the alveolar ducts. When it does that, you have a lot of plasma in the alveolar ducts of the respiratory tree. You guys remember the respiratory tree that they talked about the other night? Let's see how much you remember. Trachea, bronchi, bronchioles, alveolar ducts, and then capillaries wrap around them, right? Very good. So, if I came from the capillaries, I'm going to seep back into where? The alveolar ducts. So what you have is a bunch of what? Fluid, blood where? In my alveolar ducts. Okay? So if I take a stethoscope and listen to their chest, what does it sound like? Wet. Because I got fluid in there. So I've got fluid in my lungs. Does that make sense? So if they cough it up, and they will, because the lungs don't like that kind of crap, so they start coughing up, and they're coughing up what? Pink frothy sputum. Absolutely. All right? So let me ask you this question. This is important. This fluid that's in their alveolar sacs, what is that condition called? Fluid in the alveolar sacs. It's called pulmonary edema. What does edema mean? Swelling. In this case, there's fluid. There's blood from swelling in the alveolar sacs. Okay, so congestive heart failure can cause what? Pulmonary edema. Let me ask you this real quickly. Are there other things that can cause fluid to develop in your sacs, alveolar sacs? Yes. But today, we're just concerned with, I got fluid in my sacs from what happened? What is it that put it in this caused this to happen? We got to trace it all the way back to the left ventricle, stopped working, and blood went the opposite direction, and it just shot it right back up to the lungs and the alveolar sacs. Okay? Good. So left ventricle fails, blood stacks up in the lungs, high pressure in capillary beds, and fluid is forced out of the capillaries into the alveoli. Is that kind of what I just told you? Mm-hmm. All right. A little differently, but that's kind of what I told you. Okay, right-sided heart failure. Now we're talking about what? The right heart. And it's most commonly caused by left-sided failure. Blood backs up in systemic circulation. Very good. Now, you guys just told me that we can figure out blood flow. So, let me ask you a question. Are the signs and symptoms of right-sided heart failure going to be the same signs and symptoms of left-sided heart failure? Can't be. There's no way. Okay? So, here's the way it works. Blood comes from my head and neck down into the jugular veins, into the what? Superior vena cava, into the what? Right atrium. Blood's also doing what from the opposite direction? Coming from my lower extremities into the inferior vena cava. They both join and go into what? The right atrium. The right atrium sends it through the first valve, which sends it to what? The right ventricle. Roger that. Now, let's say the right ventricle fails. So, reverse blood flow. From the ventricle goes into what? To the atrium. The atrium it goes where?
To the head, neck.
To the head, neck. So what do I have? Jugular vein distension as a symptom. And also have pooling where? In the other parts of the body. So they have this huge swelling in their feet called pitting foot edema. They have abdominal ascites, swelling in their extremities. So what I'm telling you guys, if you can figure out blood flow to the heart, and if I tell you this side of the heart fails, where do I expect to see the signs and symptoms? If I tell you the left side of the heart fails, retrace blood flow and go the opposite direction, and you can figure it out. Okay? So you have the distended neck veins, and that's called what? Which stands for jugular vein or venous distension. Fluid in the abdominal cavity, which is called what? I just said it, big fancy word. I said abdominal ascites. A-S-C-I-T-I-E-S. Ascites. Did I talk about pedal edema? I call it something else. What did I call it? Pitting foot edema. Same thing. Pitting foot edema, which also means what? Gross swelling in their lower extremities. And so you might get to somebody's house and go, gosh, you got huge ankles. Do you normally have huge ankles? Nope. I had a heart attack 2 weeks ago. And ever since I can't sleep. When I lay down, I get all this, feel like I'm choking. and then I get all this swelling in my neck, and I get swelling in my arms and legs, and my belly swells, and my feet are huge. You're thinking, ding, 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 ding. You have congestive heart failure. Now, if I want to be specific, could this person have right and left side heart failure?
Yeah.
So they're going to have all the stuff we just talked about, the swelling here and here and here. And if I listen to their lungs and they got this wheezing sound and this wet sound in their lungs, and they're coughing up pink frothy sputum, these people are what?
Congestive heart failure.
Well, we knew they were in congestive heart failure, but now they're in both heart failure, so we're in what? Complete heart failure. Thank you. Okay, I think we know all these dyspnea on exertion, which means that they get short-winded when they exert themselves. And does it really take a lot of exertion to get them to get dyspneic? In some cases, absolutely not much at all. Okay, now here's a new word. It says paroxysmal nocturnal dyspnea, which is a big fancy word for they have difficulty in breathing at night with different positions. So typically, they go to bed at night, nocturnal, they lay down, which causes the fluid shift, fluid in my lower parts of my body. Now I lay down and it starts doing what? It's moving up into my lungs. So they have this, I can't breathe at night. So typically what they start doing is start sleeping with 1 pillow, 2 pillows, 3 pillows, 4 pillows. Before you know it, they're sleeping almost bolt upright. That's the only way they can sleep. Okay. And again, orthopnea is a big fancy word for difficulty in breathing in certain positions. And we know all this stuff, the JVD. Okay, there it is. Pedal pitting edema in the lower extremities. Find out if that swelling in their extremities is normal or abnormal. Don't get wigged out about it. Unless they tell you, that just started happening. Again, fancy word for fast heart rate and pulmonary edema. Somebody tell me exactly what is pulmonary edema?
Coughing up
Fluid in
fluid in the lungs.
Really, the definition is fluid in the lungs. And so now, how do you know they've got fluid in the lungs? And you just said, I listened to their lungs and it's wet sounding, and you also said coughing up pink frothy sputum. That is pulmonary edema. Can other things cause pulmonary edema? We're not talking about them tonight, but the answer is yes. We're only concerned about pulmonary edema associated with what? Congestive heart failure is what caused me to go into pulmonary edema. Does that make sense? Is pulmonary edema a disease?
No.
It's a symptom of what? Something else. In this case, it's from CHF. Very good. Noisy, labored breathing, coughing, wheezing, ralls, wheezing, pink frothy sputum. Okay, and that's a picture of heart failure. All right, so what are we going to do to manage people in congestive heart failure? In other words, their heart is already congested, so what do we need to do? Make it easier for them, okay? So sit them up and let the feet dangle. They're talking about put them in a stretcher, and if it doesn't disrupt your protocols, if they're in acute distress, let their feet dangle off the side of the stretcher, okay? You want to give them high flow oxygen? We are now, this slide's a little old, but we're actually trying to stay away from assisting ventilations. And the thinking behind that is if I have somebody that's got a bad heart and bad lungs and I put them on a ventilator, is it going to be really hard for them to eventually get off the ventilator? The answer is yes. They don't want to come off the ventilator. They become what's called ventilator dependent. Okay? So an intermediate step to keep us from putting them on a ventilator is something called CPAP. And most of us can relate to that. We've seen somebody that's got sleep apnea at night and they get on a machine, and that at night that machine forces air into your air passages and opens up your lungs and tells you to breathe. That's CPAP. We don't become so dependent on that. So pre-hospital wise, we've actually shifted gears and gone from I'm just going to drop a tube down you. I'm not going to do that now. I'm going to put you on CPAP because that's an intermediate step. Okay? And that's going to work real nicely for you. The other thing it tends to do is this. If I'm forcing air into your lungs, if I'm forcing air in from this direction, I'm going to the trachea, the bronchi, bronchioles, alveolar sacs, bam. When I get to the alveolar sacs, what's in there? Fluid. So as pressurized air, when it gets to that fluid, what's it going to try and do? Push it back through the other direction. Absolutely. Okay. All right. Sometimes people have what's known as pacemakers. These little gadgets that are implanted underneath their subclavian area, somewhere right, left kind of thing. Could be square, could be round, smaller than a deck of cards kind of thing. Sometimes those gadgets go out. They got a battery in them, and sometimes they just don't work. And again, what a pacemaker is, the reason Doc put them in there is because your natural pacemakers that your heart comes with are no longer working the way they're supposed to. And so sometimes your heart goes in a really fast rhythm, or sometimes it goes in a really slow rhythm. So they take these pacemaker wires, put them on your heart, and it senses all that information, and it paces the heart for you. For example, if your natural firing rate is only 20 or 40, and it needs to be around 60 or 80, so those pacemaker wires read that, it sends a message back to the thing, and it does what? It paces your heart. What? To contract every 60, 80 beats per minute. Does that make sense? So the pacemaker may be set at 70 or 80. Same thing, if it's too fast, it slows it down. Okay? So what happens when that little battery goes out in that pacemaker? So now your heart rate goes back to what? 20 or 40, absolutely. Okay? And what's really cool about pacemakers is there's a little switch on them. It could be fixed or demand. What do you think that means? Fixed or demand?
Oh.
Think about it.
Automatic, or is it remote control?
No. What it means is that person's heart rate, their pacemakers, are working occasionally, and sometimes they just need to be reminded to be beat. So they're put on something called demand, as needed. Sometimes that pacemaker is completely wiped out, and it ain't going to fire at all. It's going to fire 20 or 40 every time. So what mode do you think they put the pacemaker on? Fixed. It wants to keep firing constantly, so it's actually taken over your firing rate all the time. Versus demand. Sometimes your heart works, and we let it work when it wants to, but when it drops too low, it does what? We kick in for you. Does that make sense? Okay. All right. What we're saying to you is you really shouldn't change a lot of what you do for pacemaker failure. Just get them to the hospital, support their vital functions. And if they need CPR, they need CPR. I think the only thing I would say to you is if you have to defibrillate somebody that's got a pacemaker in, what don't you want to do?
Put it on top of the pacemaker.
Yeah, you don't want to put that directly over where we suspect a pacemaker is. And it says, do not worry about damage to the pacemaker. Again, these pacemakers are kind of, they don't like magnets. That's how they turn them on and off. Okay, so people that have pacemakers are warned, hey, you need like MRI? Ooh, huge magnets, stay away from me, kind of thing, okay? All right. Sometimes somebody may go home with a zipper, which means they've actually taken a saw, cut right down the middle of the sternum. They've cracked their chest open, they've worked on their heart, and they send them home and they wire that sternum back together. And so they may have fresh sutures and or wires and stuff like that. All that's really saying is, you know, to me, CPR is probably a little bit easier on somebody like that because they've got a very pliable chest. So don't get wigged out about it. Okay. Oops. All right, implanted defibrillator. Here's the take-home message here. Sometimes people have, instead of a pacemaker, they have a pacemaker / defibrillator. Okay? And so doc knows this person's gone into VFib before, so he takes and implants a defibrillator, and those wires go in the heart, and if it senses the heart goes into fibrillation, what does it do? It shocks it. Here's what's really cool. If you take one of them defibrillators, you got them AEDs, and you put those pads on somebody's chest, you know how many joules of electricity that's delivering? Like 200 joules, like a lot. Now, if doc puts a defibrillator inside your chest, and these wires go under your chest, and the wires lay directly on the heart muscle itself, do you think that defibrillator is going to shock at 200 joules? No. It's probably going to shock at something like 2 to 4 joules. Okay? So all it's saying is this. When you get up to somebody and their defibrillator is firing, you're going to feel the electricity from inside coming out. Are you going to feel much of anything? No. You know what they're actually advocating now, or will be advocating, is that if you're doing CPR and you show up with an AED and you're doing compressions, and you know right now we say clear and we shock them, what we're saying is you keep doing compressions, you're both going to get shocked. What do you think about that? They're doing studies about that right now. What they're saying is the shock's not that bad. Yeah. Okay, well-being of the EMT. Let me start this and then we'll get a break. All right. Okay, so some of the things that we want to talk about is, and this is generally where this is my value because I've been doing this a while, and trust me, I've gone through the whole spectrum of emotions, on scene, off scene, get back to the station, things like that. And some of the things that you're going to experience is you're going to feel sad, you're going to feel hurt, you're going to want to cry, you're going to want to beat the hell out of somebody. You're going to go through a number of different emotions, okay? We'll talk about reactions that family members will have when confronted with death and dying. I mean, that is a big responsibility. We're going to give you the responsibility to go in somebody else's home and tell this little old lady standing there that's been married to this gentleman for 50 years that your husband is dead. That is now your responsibility. Do you think that's a huge responsibility? Yeah. Just telling somebody that their loved one's dead. That's kind of hard to do. Okay? And then, how do you confront somebody or approach a family that has lost somebody or they're dying? Okay, we'll talk about the reactions that a family of an EMT basic may exhibit. Now, why are we bringing our families into this? You think you're going to take this home with you? Absolutely. There's a really good book I looked up today. I left it at the house. And what I'm probably going to do is bring it in and just, you can read it in probably 4 hours if you stay with it. And what I'd like all of y'all to do is read it at some point during this class. And the reason I want you to read it is because it's just, it really is, it goes over a lot of different venues that affect us, such as your personality, what your family's experiencing. It talks about sleep. It talks about a lot of stuff. It's just related to stress, and I think it's very, very helpful. I think it'll help you. And really kind of what we would like for you to do, those of you that plan on just kind of bearing off in this kind of stuff, is at some point have your family read that book. It really is a good book, okay? You should be able to recognize once you start working in the field that your partner is suffering from critical incident stress. And the military has their version of it, which we actually stole it from them. What does they have? What is that?
PTSD?
Exactly. Okay. And so, it took us a while to recognize, hey, they were having, in some cases, delayed reactions to some just overwhelming situations that they dealt with. Now, in the civilian sector, are we exposed to some of the same things? Death and dying and stuff like that? Can we have reactions to that? We call ours critical incident stress. Okay? In other words, it happens from maybe cumulative, several things that happen. It may not affect you the first time. It may be a while before you're affected by critical incident stress. And there are a lot of objectives here. Okay, and here's some other, let me go back this one. So we talked about the importance of BSI again. This is body substance isolation, or PPE. And some personal steps for personal protection against airborne and or bloodborne pathogens, and just a different equipment you probably need to wear. Okay, I'm not going to read all those to you, but your personal health, your safety, your physical health, and your emotional health, I think your physical and your emotional health are probably the most important things you're going to have to deal with, okay? And so again, like I said, a lot of us come to work, and it would be nice if we could just leave our personal baggage at the door and come into our jobs and not let that carry over and kind of direct some of the decisions we make or the temperament we have, things like that. But it's too hard. It's not that easy. And even if you were able to do that, you're going to get a phone call, you're going to get a text, you're going to get those personal problems are going to kind of creep into your daily, work day. And so it's hard to just kind of shut that kind of stuff off. Okay? Again, learn to recognize and protect yourself from the hazards. We keep talking about scene safety and stuff like that. And it's really important that we recognize that scene assessment and making sure a scene is safe is what we call a dynamic process. It's not static. We don't just check it when we get there and go, the scene is safe, and therefore it'll stay safe. It's something that we continue to watch. Okay, I'm watching that guy in the back of the room, and he had a funny look, and he didn't really look like he was happy with what I was doing over here. And kind of watching his body language and stuff like that, and now he's getting closer. I'm going to keep my eye on him, okay? And again, coping with mental and physical stresses that we face. Okay, there's a whole lot of nothing there, but death and dying, bottom line is people are living a lot longer. We're gonna, the nature of our job, I truly believe it's a privilege to have a job where I'm there when somebody's born or when somebody dies. And I may be the last face, I may be the last opportunity, the last ray of hope for them. And I think that's a privilege. And I don't think we should take that lightly. I think we need to take that seriously. And I say that because, I'm coming off a really bad call that I had about 4 years ago, and I'll probably share it with you at some point. I have a presentation that I use for that. But a young man died in my care while I was taking care of him. And he lived for probably pretty close to an hour. And the whole time I knew this kid was going to die. And that was kind of a hard thing to do, is just kind of watch him fade away and trying to make sure that I've done everything that I can for this kid before he checks out. Okay? Okay. Death is something that you're going to have to face. And most of us, unfortunately, have had to face it already in our personal lives. But what happens when it's something that's expected of us? You know, it's something that you cannot walk away from. You know, in our personal lives, when we've had to face death, we've dealt with it on our own level, and we can choose to walk away from it. We can always put as much distance or buffer between us and death, and that whole process. But when I walk in a room and somebody's dead, I can't walk away from that. I got to work through this. My personal feelings got to work through this. I got to tell somebody that somebody's dead. You know, I got to tell them that another family member is dead. So I have to work this whole process. I wish I weren't here. And I'll give you a really good example. Years ago, I made a call, and the call was that it was early in the morning. It said 40-year-old possible DOS, dead on scene. We get on scene, and as I pull up in the front yard, there's a man standing there. There's several small kids, but I notice there's a huge space between all of them. And so we get our stuff out of the engine company, and we're walking to the front door, and this guy has no shirt on, and he's like, you can put your toys up. She's already dead. Exactly what he said. Put your toys up. She's already dead. I thought, first thing that bothers me is somebody in this house is dead. Why aren't you in there? And why aren't these kids coming to you for comfort? So as I'm walking past, I hear someone crying in the background to the house. And I walk in, and I turn a corner, and there's this lady on her hands and knees, and she's holding a 4-year-old, not a 40, but a 4-year-old kid. And I look at this kid, and before I even get to this kid, we talk about situational awareness. As I walk in, I look at this, I'm going, what is wrong with this picture? And this is clearly a kid's room. And the room is perfect in every sense. Everything is tucked in. Everything is symmetrical, lined up. Toys are exactly where they need to be. The room is perfect. Now, that strikes me, I don't know about you, but that strikes me as pretty odd with all the little kids around. And so, as I walk in, I separate mom from the kid so I can do my assessment. And clearly, I have a bad taste in my mouth from the minute I walk out of the engine. So I looked at my captain and I said, secure the door, nobody else comes in. We've got a crime scene. And anyway, so the point I'm trying to make, long-winded as it is sometimes we don't have to face this. I knew my wife was coming on the ambulance. She was the one on the ambulance that day. And I did not want her coming in being exposed to this. Okay? Somehow she sneaked through my captain. She squirted right past him. And she came in there. And she was a part of that. And now she has issues with that. How can you not? Long story short, this guy was live-in boyfriend, and he had taken this little girl, and he had taken her because she didn't square the room away like the way he wanted her to. So he held her head in the commode underwater as punishment. And then later on he had taken her and slammed her against the wall so hard that she had an internal brain bleed, and she died in her sleep from, a huge bleed to her brain. So, is that a tough call to make? Yeah, they're tough to make. Knowing all this stuff is really hard to make. So, again, situational awareness, because when you know you're going into a crime scene call like that, do you think that you're going to be called into court on a case like that? You are. And you're going to be expected to remember, and I was taking mental pictures every time I could. I could tell you now what she was wearing, what position she was in, where her leg was, what her hands across her chest. I could tell you everything about her because I had to take that mental picture, because we don't touch anything. We just make sure that she is deceased. At that point, it's a crime scene, and we don't change anything. And that's the other reason you don't want a whole bunch of people coming in there, because this is a crime scene, and the less stuff we can disturb, the better. All right, the second part, coming to grips with death, is a part of delivering care. We know, well, I know when I show up to work tomorrow, I may have it. Just the other day, just last shift, had a kid run his car into a tree. And we get the call to get over there, and it says, somebody's buried in the car, it's burning, and they're burning alive. Turns out that there were a bunch of heroes there, and they pulled the kid out, and they started putting water on the fire before we got there, so they were the true heroes. But that kind of stuff happens all the time, just when you least expect it. You let your guard down, and bam. I mean, we could be sitting around the station watching TV, cutting up, having fun, watching a movie, and next thing you're faced with a kid that drowned. We had a kid that drowned in Belton the other day, didn't we? How do you think? What kind of emotions do you think you're going to go through when you face that kind of call? Okay, so part of what you guys need to know is when I tell you to go in the other room and find out if somebody's dead, you need to find out. You need to know what qualifies as dead. Because I guarantee you right now, if I were to tell you to go in there and say, is this person dead, you're going to go, I'm probably going to get several different answers. So we want to give you what you can walk away with saying this person's dead. Because I tell you what my greatest fear is to walk in a room and say, your loved one is dead. And then 10 minutes later, somebody walks up and go, hey man, they're breathing. Screwed that one up. But anyway, so the physical signs of death again are they have no pulse and they're not breathing. And the second bullet says if the body is still warm, initiate care. Okay? So in theory what we're saying is, how do we know that they're dead? Well, we kind of check their core temperature, and if they're stiff and if they've got dependent lividity and stuff like that, and if they're warm, then we probably need to initiate care. Okay. The exception to the rule is if hypothermia is present, you want to initiate care. So what we're saying is, if you go up and somebody's dead and their body's real cold, yeah, they're dead. We're not taking that away from you. They're dead, but they need a chance. They deserve the opportunity to go through the rewarming process to get their core temperature back to normal. And if they're still dead after that, then we're okay with that. So if they're cold and dead, we want them warm before we call them dead. Does that make sense? Okay. These are the things we use to presume that somebody's dead. Okay? And I mean, I could be really comatose and have other problems and not really be dead. I could be fresh dead, or I could be dead a long time ago. So these are presumptive signs of death. Now, yeah. All right, dependent lividity. Can anybody tell me what that means?
It's usually pulling of blood.
That's pooling of blood, exactly. So you take that word dependent and lividity. So when the body dies, for example, if one dies and they're in the face up position laying down on their back, okay, what happens is blood will pool out and pool to the lowest parts of the body. Okay? So when you roll them over, what you'll see is huge pools of blood in the lower parts of their body. Okay? And that's called dependent lividity. Okay? What I generally do is I don't just use one indicator to say this person's dead. I use multiple indicators. Okay? They could be totally blue, and of course decreased body temperature, but that's not one that I'm going to rely on solely. What you guys want is definitive signs of death. In other words, I walked away, I told the justice of the peace that patient in the other room was dead. I wanted to make sure that I've done this correctly. So the things that I know qualify for death are obvious mortal injury. What's a mortal injury? What's that? An injury that the person cannot survive. Decapitation is one. Bodies severed in half. Okay? Obvious mortal injuries that are incompatible with life. They have half their head gone, they're still going. They're still breathing a couple of times, but half their brain is gone. Okay? So again, obvious mortal injury. Rigor mortis again is what?
Stiffness.
Now, when your body starts to get stiff. Okay. Now, the questions I always ask is, how long does it take for rigor mortis to set in? The answer is, it depends. And the depending factors are, what is their underlying health, weight, ambient temperature. Some of the factors we use are those. The parts of the body. So the jaw is probably one of the first areas to develop some rigor mortis. Smaller bones are going to develop rigor mortis first. So again, it just really kind of depends. Generally, somewhere around 2 hours, you're going to start seeing some rigor mortis. Okay, decomposition of the body is another one. And we'll take a break right here.
You know that last slow we shuffled?
Couple of years.
Yeah.
Probably
5, 10 years later. Yeah, my wife just got one when she used to work at Marlin. She worked at Marlin 8, 9 years ago. She got caught on a violent rape. She goes, I don't even remember the case. All right. Now, stages of grieving, and generally we're kind of talking about the family now. Okay? And so these are some of the stages that you might see. Now, please understand that these people didn't see this slide, so they don't know what stages they're supposed to be in. And when you get there, you can't say, hey, wait a minute, back up. You're supposed to be in the denial phase first. That's the way it's written on the PowerPoint. You're a little ahead of me. Let's back up a little bit. They could be in any one of these stages, couldn't they? Okay? And so you just kind of understand that these are just some of the steps that they could be going through, okay? So what is it that we can do? It says that we can do helpful things. And just some simple things I would offer, for example, is little lady, husband's dying, dead. She's just distraught. Honey, can I help you make some phone calls? Is there a clergyman, a preacher in town, your neighbors? Can I get somebody over here for you? Okay. You can make simple suggestions, things that might simplify things for them. Okay. Family members may want to go back in and view the body. Is it okay to let family members view the body? You know what? I don't have any one formula that I use. I kind of use different formulas when I deal with stuff like this. and I kind of base my decisions based on how everybody's reacting and things like that. So if somebody wants to come in and view the body, okay. These are kind of the guidelines, though. You can't touch anything, you know, things like that. So just you kind of got to go with the flow, so to speak. You should, I say you should be yourself and sincere, unless yourself is like a jerk. Then don't be, you know, be somebody else. But you should be sincere about your actions, what you're saying, how you can help, things like that. Now, imagine you're a family member and I'm dealing with you. You would probably want me to act in a calm manner. Sometimes it's very difficult for us to maintain our composure. It's really hard when somebody comes up to me and tries to spit on me or takes a swing at me. Okay? It's really hard when somebody starts cursing at me. But I say to you guys, you've got to be able to sift through all that crap and not take things personally. Understand that little kids in the backyard, somebody's doing CPR on them, you get there, and the first thing that happens when you get to the front door is this huge man is screaming at you, and why in the frick did it take you so long to get here? What the hell are y'all doing? And so you're like, holy crap, what's going on here? And what kind of emotions do you think he's going through? Anger. Anger? Do you think he may be going through some guilt because he was supposed to be watching the kid? So there's a lot of emotions he's going through, and he's going to take it out on you. And you got to understand that I'm not going to get in a pissing contest with you right now. In fact, I'm not going to get in a pissing contest with you at all. I really need to be back there to your son and help take care of him. Okay? So you've got to be able to very quickly put your shields up and go, okay, you're not going to get to me. I've got to take care of business. It says, respect family wishes. That's kind of, again, be open-minded about what it is we can and can't respect here. You should be honest. If somebody says to you, are they going to die? Are they dead? How do you tackle that question?
Tell the truth.
The thing is, I don't know if they're going to die.
Well, if they are dead, you do know.
Exactly.
Only answer what you do know for sure.
That's a good answer. I had a case not too long ago, and a lady who had been sick for a while. She was from out of town, staying at a hotel. And we get in there and we start doing CPR. And so there's several of us doing CPR, and I said, guys, you guys keep doing what you're doing. I'm going to go talk to the daughter and tell her what's going on. So I went and talked to her and said, look, your mom's not breathing. Your heart's not working. Right now we've done a whole lot of stuff for her. We've given her medications. We've shocked the heart. We've done a bunch of stuff for her. And right now she's dead. And there's probably a good chance that we're going to stop doing what we're doing after we talk to the hospital. Are you okay with that? Yeah, I am. Okay, I said, we're not to there yet. I need to go back in there and see where we're at. But I just want to kind of prepare you for that next move. And I walked in there. Guys are doing CPR. I says, do we have a pulse? And they go, oh, no. And so a bunch are going like this. No, we don't have a pulse. And so this is 2 lessons learned. So I went straight to the femoral region right here. And I felt, I'm going, boom, boom, boom. You can see my fingers jumping off. I said, she's got a pulse. So I've just told this lady what? But I was telling her the truth. At that time, we didn't have a pulse, but now we do. So we shifted gears. We go, well, we've got a pulse right now. And the first thing that she said, because she was listening, she goes, oh, she's back. I go, ma'am, you need to understand that may be temporary. We've got a pulse right now, but that's just temporary. It could be some of the drugs kicking in, and that's exactly what happened. The drugs kicked in, her heart came back, but anyway, she faded back again. So again, honesty is really good. You shouldn't create false hope when hope does not exist. Okay, and so these are some of the things that the critically injured or dying patient express to you. Anxiety, seen that a lot. Fear, anger, hostility. Oftentimes, again, that lashing out at you is nothing more than they're being guilt. They feel guilty. Depression. And again, these are just some other things they may feel. Guilt is a big one. Gosh, that's a big one. That's huge. Especially when you have two parents fighting because their kid is injured. You were supposed to be watching. No, you were supposed to be watching them. And all of a sudden they start fighting against each other. Okay. All right, you should avoid sad and grim. Sir?
What would you do in a situation like that where it became like a violent situation between the parents?
Well, we generally try it within reason to try and just get them to calm down. And short of trying to separate them, you know, I usually say helpful things like, look guys, you guys are upset. You're making it difficult for us to help your kid. Y'all just need to stop. And again, you know, then we turn it over to PD. What we don't want to use is the biggest hammer we've got in the box. You don't want to slam and go, okay, PD, take care of them. Because the worst thing that can happen is my kid's hurt, now I'm getting arrested. That sucks, doesn't it? And I try to avoid that. I try to say, look, you guys just need to cool, chill out. You're not helping anybody, you know. And I try to put the guilt back on them. Y'all are so loud, so distracting, I cannot help your child. And usually that helps. Probably wouldn't be a good thing to walk up and go, holy crap, I've never seen anything like that before. You know, that's not a good thing. I like the next one. It says orient the patient. Can you imagine being in the back seat, you're asleep, you just pulled your 3-hour shift of driving, and the next thing you know, you wake up and you're laying face up on a highway and you see my ugly mug looking down at you. You have no idea what happened. You assume you were in a car wreck, but you don't have any idea where you're at. You don't know anything about the person that was with you. And we oftentimes assume that, hey, you know what's going on. No, I don't. I live in Tennessee. I was driving through, last thing I remember, we were in Mississippi. Now you're telling me I'm in Texas? What happened? Where am I at? Where am I going? Where's my buddy? All that kind of stuff. Exactly. So keep them oriented. You know, what about if the family, they're separated? First thing a parent wants to know is what?
Where's my child?
Where's my kiddos? Absolutely. Okay, you should acknowledge the seriousness of the. I always do that. I always go, you know what? I got to tell you, your mom's not breathing, the heart's not working. Man, I mean, that stuff flows out of my mouth pretty quickly. And I'm not trying to be grim. I'm just trying to be honest. I'm trying to move you in the direction, especially if I know that they were dead before we got here. And there's those cases where you're going to get there and you know they're dead before you got there. You may be going through the motions, okay? Again, help to locate and notify family members is always a nice thing to do. these are some of the factors that would affect patient reactions. Certain socioeconomic backgrounds. Some people are just totally afraid of medical people. They may be under the influence, so again, they may be altered in their thinking. Chronic diseases, you know, I really don't care because I've got terminal cancer. Mental disorders is one, medication reactions, and certainly age. Okay, critical incidents. Critical incidents are situations where you as the caregiver have been affected by it. And generally, we're not affected by it physically, we're affected by it emotionally, okay? Which could render us incapable of providing care. And I'll give you a quick example. I arrive on a call, and this is a call with a car wreck on the interstate with multiple casualties. The engine company's gotten there already. This is back in the day when we still had ambulances. So I arrive, and the captain on scene looked at me. He's got tears in his eyes. The first thing he says to me is, "You got to take over because they're doing CPR on my daughter." And now, is that a lot of pressure? Absolutely. And so I said, "Okay, I'll take care of it. You just stay here." So, so I go through and I start making assessments on all of the kids that have been injured. The one that's been injured that they're doing CPR on has been thrown over the guardrail on the embankment, and they're doing CPR on this girl. And as I walked by this girl, I looked at her and I'm going, that's not his kid. And it wasn't. But that kid looked like his daughter and was wearing the same thing his daughter would have worn. But when he got there, what did he see? He got tunnel vision, and that was his daughter. It didn't matter what made him incapable of taking care of that, but it had just happened. And this stuff could happen to you when you least expect it. And so it was a bad thing that the child died, but for him, I mean, it was, you know, he was lucky it wasn't his kid. But anyway, mass casualty incidents, critical incident again. Mass casualties when you have a lot of people injured at one time, okay? When you have a traumatic injury to the death of a child or a car wreck, that's what MVA is, motor vehicle accident, caused by EMS personnel. And we're involved in those situations, again, those are things that are going to impact us.
How often does that happen? Often, even if the EMS in a car wreck?
Bad wrecks, not too often. One that comes to mind is in Waco, East Texas Medical, about 2 or 3 years ago. One of their supervisors was responding to assist one of their ambulances on a call, and because he's a supervisor truck, he's having to flip the pages to look up the address. He wasn't using a GPS, didn't have it at the time. So he's looking up the map, looking up where he needs to go, and the next thing he does, he looks up, he runs right back into the back of a street sweeper, and he's killed instantly. Not only that, he's pinned in. So it'd be one thing if okay, your dad would get you out of the car and would get you out. No. Now we got to stand by. Now we got to cut you out of the vehicle. So that just prolonged that anxiety for a long period of time. It does happen. Fortunately, and I hate to even say this, but our numbers are really low in this area. But we do have wrecks, trust me. I've been in a few. Okay, what is critical incident stress management? Well, what it is, it's a organization that was developed back in the 80s. How many of you guys remember the Luby's massacre incident here in the area. Okay, how many guys remember the Branch Davidians? And then recently Fort Hood. So usually when I go off to class somewhere, out of state, they go, "Where are you from?" I go, "I'm from Temple, Texas." "Where's that at?" "Well, that's the center of Texas." "I don't understand." "You remember the Branch Davidians?" "Mm-hmm." "Remember the Luby's massacre?" "Mm-hmm." "Remember the Fort Hood shooting?" "Uh-huh." And we're in the middle of all that stuff. So the question comes up, do you ever see mass casualty events like this around here? There's just 3 prime examples. We see it. Okay? But anyway, so the Branch Davidians, David Koresh here on the outside of Waco, he was a spiritual leader, and he had a compound there, and the FBI raided it, and they actually threw in some incendiary devices, and it burned up, and several law enforcement officials were shot and killed. A lot of people were killed.
It wound up being like a mass suicide.
Yeah, this went on for like weeks. Finally, it boiled over.
I don't remember.
You just Google it up. Branch Davidian, David Koresh. Read up on it. It was kind of a. But anyway, critical incident stress again was developed in the 80s, and what it's designed to do is it's help for EMS folks by EMS folks. In other words, if I had a problem and I had to go to a mental health professional, am I going to open up? Maybe. But if I had an outlet, and this is the way I was in the incipient stages of it around here, the way it kind of was developed is that, okay, when a call comes in 20 minutes that a kid's just been hit on a bike and it's drug underneath the car and he's pinned underneath the car, who's going to be affected by that call? Dispatcher who got the call, the police officer who got there, the fire guys, the EMS folks, Scott and White's staff. You see where I'm going with this? So everybody's going to be affected by this. So we recognize that if you make me talk a fireman, you make me talk to a mental health person, I'm not going to open up as much. If you make me talk to a dispatcher, I'm damn sure not going to open up. But if one person in this group is also a firefighter, am I more likely to open up? Yes. And so what we do is we take people from every one of those disciplines and we train them. And now they become your critical incident management team. And so they're in a state of ready. So when something bad happens, we get a call from the fire chief in Belton that says, "Hey, we just had a kid that was killed on the interstate. We need to activate the team." And so we'll activate the team, and an invitation will be extended to people directly affected by that call. You can't just have heard about it and say, "I want to go because I want to hear what they done. I want to hear what happened." No, bullshit. You don't get to come. You only get to come what? If you're in that direct incident, okay? And so we start by opening up. It's not mandatory, but you can't leave. Once you're there, you're there. You're not on duty. Take your radios off, take your pagers off, put your phone up, and the mental health professional starts the introduction, says, "Okay, we're here to just talk about this." And there's different stages of the critical incident stress. We'll talk about, what we're going to be doing, and then the recovery phase at the end. But part of that is we actually will start asking people, okay, what's bothering you about this call? And we want to hear the firefighter say, "Well, what bothered me the most was that this kid, his arm was cut off, and it was buried around the axle, and we had to cut it off. We had to cut it out of there." So that's what's bothering me. And so you see where I'm going with this? We talk about things that bother you. And so generally a critical incident stress is like putting a puzzle together to get a picture. Because part of what's bothering you about a critical incident stress is what? That you couldn't help. You didn't save the kid. But the reality is when the police officer tells you what he saw when he first got there, the fireman says what he saw when he first got there, the doc or the ER nurse says, you know what, the kid had already lost over 7% of his blood. We start seeing what? And the big picture is what? The kid was dead before we got there. Does that make sense? And nothing was going to change this. And so it kind of helps us re-enter, reconnect, so that we can be effective again. Okay? I'll give you another, but anyway, another step of it here in a minute. Okay, so the pre-incident stress education is what? Letting you guys know what? This exists. There's an outlet. There's an organization. There's a group. Okay? We want the fire chiefs to know. We want the EMS supervisors to know. Hey, if something bad happens, we're here. We're not going to force ourselves on you. Because remember the Murrah, Oklahoma City bombing, Murrah building? We had CIS teams just showing up. They weren't invited. They just showed up. You don't show up unless you're invited. Sometimes you have on-scene peer support, and that's really a great opportunity. You get there, your buddy's there with you, and I'm having a hard time dealing with, and man, maybe all they got to do is, man, just the power of touch is incredible. It's just, it can't be overstated enough. I mean, just touching somebody and connecting them, because they wouldn't otherwise accept that. I remember we had a call. I had some hardcore firemen working with me, and we had a guy that ran his semi-tractor trailer to the hotel right off the interstate. Do you guys remember that call? That was a complicated extrication. We cut that guy out of there probably an hour and a half later. Very complicated kind of thing. Walked out there, and broad daylight, there's two firemen come up to me and hug me, and they never show emotion. That's just very uncharacteristic of them. But the three of us were involved in this case, and we're like, thank God we got him out, and he's alive. He's still alive, kind of thing, So, anyway, that on-scene peer support is, man, some of the best medicine you can get. One-on-one support. Is just talking to somebody you trust. And, talking to your pastor, your preacher, has a lot of value if you're, a spiritual person. But what about those people that aren't? What outlet do they have? So generally it's somebody that I trust. Somebody that I trust my life with. Somebody that I can talk. I can't even talk to my wife about this kind of stuff, but I can talk to my buddy about this kind of stuff. You may have that person in your life that you have that ability to do that with. Okay? All right. I'm going to talk about diffusing just for a second, okay? If somebody walks by and throws an old-timey stick of dynamite in here, and it's got a fuse about that long, and it's going, we're all going, holy crap. That's stick dynamite. Okay, what are we going to do?
Step on the fuse.
Yeah, we're going to step on a fuse, pull the fuse out, throw it back out. I mean, we're going to do something, right? But diffusing is something that we have an opportunity to do what? Recognize there's a problem, and we can change it before it gets really bad. And the best example I can give you is I was on duty one night, and I got a call from my chief. He says, "We got a problem." I said, "What's the problem?" He goes, "Well, just come over and I'll tell you." And this is the way it went down. We had a group of firefighters that went to a high-rise where elderly folks live, and it was called in as a possible suicide. So they walked in thinking, guy took a bunch of pills. As they walk in the door, there's a guy sitting right there where you are. He's got a gun underneath his jaw right here. So the senior medic in that group said, "Okie dokie," and said, "Everybody back out slowly." So they backed out. They went down the hallway. He called for police backup. Now, while he's doing this, one of the kids in his group just got out of paramedic school, so he's what? He's God's gift to paramedicine. So what do you think he does? He goes back in the room. When he opens the door this time, all they heard was a bang. So who got shot? It could have been the medic. In this case, it wasn't. The guy pulled the trigger on himself. Blew his brains out. Okay, so that's the case. Chief goes, "This is what I got. I need you to defuse this. Tell me where we're at with this, what we got to do with this." So part of what I did was call the whole team in and said, "Okay, tell me what happened." And part of the process is not, because it's real easy for us to do what right now? Point the finger. And it's real easy to say, "You know, what the hell were you thinking," kind of thing. And I just said, "What happened? This is what happened." And so part of my response to them was, you know what? That guy was pretty miserable. He was going to kill himself. In fact, he was so miserable that he wanted somebody else to feel his misery. And he was going to kill himself one way or the other. Okay? But he wanted somebody else to feel his pain. And you cannot let him defeat you, because he's going to defeat you. In other words, that kid could have done what? He could have said, "You know what, that's my fault. I screwed up. I don't want to be a paramedic anymore." So my job is to do what? Try to salvage this kid. And then, of course, make a recommendation to the chief and say, "Hey, you know what? I've heard what the kid's got to say, but I really think he needs some private time. He needs somebody to hug him, hold him, and squeeze him, and love him, and kiss him. And I love you, Chief, but I'm not going to do that for you." He needs to go home to Mama and let that be taken care of. And so we let him off for the rest of his shift. Okay. In fact, we let the whole crew off. Why?
For the whole crew.
Exactly. And what else? If I let this one kid off, what does it look like? Exactly. We're pointing the finger at you. And so the whole crew goes home. And so you guys go home, get loved on, that kind of stuff. Come back next shift. And so that crew did all right. But that kid, you know, it probably took him a little bit longer to recover, but he was okay. But it could have been a situation where we lost them all together in more ways than one. Okay. And then again, there's just some different services available through the CISM system. Those of you that read the book that I'm talking about, they actually have their point of view about CSM, and what they're saying is that part of this process may serve to weaken the individual. And what it really is trying to say is that we probably have a greater coping mechanism than we think we do. Okay, stress signs of work, just basic things. This is just really a bunch of caca here. Yeah, if you're stressed at work, yeah, you're going to get tense. You're going to get an increase in your blood sugar levels. That's kind of neat right there, that increase in blood sugar level. You see that when you're stressed? It's kind of cool. Like I may have mentioned, my wife works up in the unit, and she takes care of open hearts. And so they automatically go on an insulin protocol. In other words, what happens is because their body's been stressed because they had that open heart surgery, their sugar levels will do what? They'll spike. So what do? They put them on insulin not because they're not diabetic, but because what? Their sugar levels spiked, and we give them the insulin to bring the sugar levels down. That's kind of interesting. Okay, stress warning signs. Yeah, you start watching your partner and they're edgy and they're jumping up in the bed. They don't concentrate. They can't give you the address that you're asking them for. They say my traffic clear on the right, and traffic just comes by and almost hits you. They're anxious. They're not making good decisions. They're not eating. They're isolated. They're not part of the team anymore. And you're going, I wonder what's going on. And you remember that you guys made that kid drowning 2 weeks ago. Could he have a delayed response and reaction from that? Absolutely. So some of the things that will help, obviously, are things like this, lifestyle changes. And sometimes people just need to go to the mental health specialist to help them. Some environmental things that you can do is they can request assignments to allow more time with family and friends. Maybe go to a different shift, go to a different company because they're not so busy out at that station, things like that. And again, seeking professional help as needed. Why don't people like to seek professional help? Because of the label. You get labeled as what? Being a punk. You can't take this. You know? All right. Yeah. We're going to get to the stuff we want to talk about here. Yeah, body substance isolation. Remember that you guys are properly protected. Remember that body substance isolation assumes all body substances are infectious. Clear fluids, bloody fluids, sneezing, airborne stuff, whatever. You see those first two, it says hand washing, and below that says your best protection? I think that's a test question. So the best protection to help you against, keep you from contaminants is just good hand washing, okay? So make sure you're washing your hands before, after. We carry the disinfectant on the engine companies because we work a case, we wear our gloves. And remember, gloves aren't 100%. Depending on the glove, the level of glove your company, organization buys, some of these can have up to 40% leakage. Okay? So if your company's buying a cheap level glove, you probably need a double glove. Probably not a bad idea anyway. Okay? Especially if you're dealing with multiple patients at a mass casualty event. You know what I mean? You're going from patient to patient, things like that. When I was on the ambulance, I'd double glove. What I'd do is we'd take care of the patient. I'd have a set of gloves on. I'd take them gloves off, and then I'd go drive the ambulance. Okay? And that way I still had clean stuff off. Clean. Because what do you do in an ambulance? Everything. Well, let's say you're not wearing gloves. You take care of this patient that got poo-poo. Okay? So you go drive the ambulance. Now you're smearing poo-poo on the steering wheel. You pick up the radio and you're calling to tell them where you're at. You're hitting the buttons on the siren, all that kind of crap. So you just disperse poo-poo all in that engine. Okay? And this is like your 10th call. And you're going, you know what, screw that. You know, we need to go eat now. Right? You forgot about that poo-poo episode, so you go over to Arby's and you go, give me the double and double order fries and all that kind of stuff, and you set that sucker down. And then so you start driving, reach for a fry. You know where I'm going with that? You don't think about that, but that kind of stuff happens all the time. Okay. Again, goggles are good to prevent from splashing, spitting, vomiting, spurting. We've had people vomit on us, spit on us, splashing. I had a friend in Austin EMS. He's actually a physician now. and he had a trauma patient. The patient was positive for HIV, and when they moved him, it splattered up, and he got blood in his eyes. One of our guys just got blood splatter in his eyes. So, wearing goggles is, believe it or not, we made it mandatory about 2 years ago that we have to wear goggles. Before then, it was optional. Isn't that goofy? It is goofy.
You know, wear actual goggles or just the safety glasses?
We have goggles that have some kind of side protection. They're not the goofy lawnmower vented hole kind of thing. Anyway, there's different levels of masks that you can wear. You can wear these HEPA. When we had the, what was it, a few years ago that we had the swine flu, and I was in training back then, I ordered like 10,000 of these masks, and everybody was ordering 10,000 of these masks. And so now we've got a huge closet full of these things that probably have an expiration date on them. Gowns. I don't really, I rarely look like that because I don't have the hair or the eyes for it. But if you have to, when I do look like that is when I'm going to help deliver a baby. When I'm going to help deliver a baby, I don't want to look like a giant condom. I really do. Because you got stuff coming at you from every direction, okay? Especially babies. All right. Scene protection, wear the right stuff. This guy is well outfitted. Photo op kind of thing. Body armor, hopefully, and there are some EMS systems that require some of their trucks in some of their districts to wear body armor and things like that. Okay, just a little bit about concealment versus cover. Conceal hides your body, and cover kind of hides and protects. So, the bush is not really going to, somebody starts firing at you, it's not really going to help a whole lot.
I feel like that was an ironic slide.
What's that?
I feel like that was an ironic slide considering the people we have in this class.
I don't know if I take offense to that or not.
No, you shouldn't. Don't take offense. It's positive. I feel like people in this class are going to take cover. They're going to pull out a gun and start shooting back.
Holy crap.
Oh, boy, Jesus.
What?
No, not one.
There's not classes Saturday, is it?
Yes.
Oh crap, I gotta tell Jeff that I will not be here this Saturday. I don't even know why I didn't tell him that.
So, no this Saturday?
Huh?
No this Saturday? Or are you having just some?
I won't be here. Somebody will be here, but it won't be me.
Lucky
So still
you.
8:30 or 8? Because you won't be here.
8. All right, this section is communications. And this is really, there are going to be some test questions that I'll try and point them out as we go. And this is just really the communication link. If you ask anybody that's ever been involved in an event, a major event, and you ask them what was the one thing that could have worked better, and what they'll tell you generally is communications. One of the things that generally fails is communications, and sometimes it's just landlines, sometimes it's the ability to access the tornadoes they had recently in Alabama and Missouri and stuff like that. That stuff's knocked out. We were trying to call family there. You couldn't get through. Everything was down. So communication between the party needing help and the dispatcher. This lady just witnessed a car wreck. So she's contacting, in this case, she's using a landline, a telephone, and she's calling 911. Why is she calling 911? Because that's kind of a universal number that we use to contact.
Then
The
because you don't need to pay money for it.
what's that?
Then and because you don't need to pay money for it.
On the payphone, it's free. Call 911 is free.
Even on your cell phone, if your service is denied,
You still can
you can
call
still call 911, it'll still.
You there, really?
But even if your phone is off, it will activate. You can call 911.
Anyway, via non-public telephone or radio from fire, police, there's just different ways to contact the emergency systems. Dispatch obviously is these folks, this is where they take all the information, they're asking a bunch of questions, and just the other day, the call I was telling you about, the kid ran into a tree and exploded and fire and all this kind of crap. The lady, after we took care of this kid, I'm checking on their welfare and stuff like that, she goes, I got a problem. I said, well, what's the problem? She goes, I want you to know I called 911, and I called that lady, and I said, you know, I was inside my house, we heard a loud explosion, we went outside, and this car was on fire, and a kid was trapped in it, and I said, send me a fire truck, send me an ambulance, send me a police. And she said, and then she said, the dispatcher started saying, well, what color is the car? How many people are in it? What's the license plate number? And, I mean, she's just asking a cajillion frickin' questions, which is what dispatchers do. And what I had to do is I said, ma'am, what I want you to understand is I can appreciate your frustration because I went through it myself not too long ago. But what you need to understand is a person that initially took your call is called a call taker. What she's going to do is take that information the minute she determines the resources needed via computer. She's sending that information to another position in that 911 center called a dispatcher. And the dispatcher is now, okay, this happened on Creekside in Temple, Texas. So she's activating by district the engine company, the fire truck, police and EMS and all that kind of stuff. So it's a seamless operation. She's doing that simultaneously. But all she knows, this lady knows, is what? She's asking me a cajillion questions. A, I can't answer. I don't want to answer. And it was kind of funny because I was reading my notes on my MDT, and it said, calling party was belligerent and refused to answer questions and hung up on me. I said, well, I probably would have hung up on her too, because they ask a bunch of stupid questions as far as I'm concerned. They really don't need to know what color the car is. It's really the only car on Creekside that's burning right now.
The license plate's on. The car, I really can't see it.
Okay. And so some of the things that they do is they can page out in volunteer systems. They can call a house, radio voice communications, cell phone, and MDT, which is mobile data terminal, which is what a lot of services have in their vehicle. They'll have a computer, and that computer, that's how they, give you information. They give you the address. They give you special notes as you're going to the call and stuff like that. I love the MDT because it really just helps me a whole bunch. So some of the dispatch and EMS unit, what they like to hear is, A, I'm en route, I'm on scene, I need these resources in addition to what we have here, we're leaving the scene now, we're arriving at the receiving facility, which in this case would be the hospital, and I am now back in service. So what that allows the dispatcher to know is, okay, I've got a call finished, and so I got 2 calls holding, so now I'm ready to redispatch you to another call. Okay. Now these are some of the things that the dispatcher can do. They can kind of help with navigational problems. They can give you immediate assistance or information from other agencies, and they can kind of help coordinate units. And again, dispatcher is just sending you to a call. Really, as a person responding to the call, you need to make all those decisions. One of the things I hate is some of our captains get on the radio and talk to the dispatcher and ask the dispatcher, what do you want me to do? It ain't her call. You're getting paid to be a captain, so be a captain. You make the call. You make the decision. All right. Sometimes we want to call the hospital early to let them know we've got a really bad call coming in so they can get all their surgical services down. We can get online medical direction, talking to the doc, saying, hey, this is what we got, what do you want me to do? And what you might find out is, hey, we just took we had a shooting at a nightclub, and we can't take that trauma victim, you're going to have to redivert to another facility. All right. Yeah. All right, so what are some of the other ways that we can communicate if the systems go down? Have you guys heard of CERT teams? They're called Community Emergency Response Teams. And we developed a team here in Temple a few years ago, and I've worked with them and trained them. And one of the things they've done is they're amateur ham operators. Some of them are. And you wouldn't, people think, oh, they're a bunch of goofballs and blah, 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 and they got 10 antennas coming off their cars. Well, you know what? In a disaster situation, they're the only ones that can communicate with somebody, So they absolutely have their value. And you need to visit with all the resources of your community and befriend them and use them when you need them, because they will come when your systems go down and you can't communicate with anybody. Okay? And these are just some of the other different ways, citizens band and commercial broadcast, business radio, things like that. Business radio would become in handy when you've got a large manufacturing process, and right across the street there's a large brown plume, and they've got hazardous chemicals coming out. So I might get on the business radio and say, hey, we're going to do a shelter in place. We're not going to, because we get you out in this stuff, and you're in it to win it now. So we want you to stay in the building, and so these are some of the shelter in place procedures we want you to do. Okay? Could we shelter in place in here if we had to?
Yes.
Absolutely. Okay, so what we do, something like this, is one of the first things we need to do is turn off the HVAC systems, control that. And then we make this room as airtight as we can. Okay, EMS Communications and the FCC, they control all radio communications and allocate specific radio frequencies for use by EMS providers, and licensed base stations and assign call signs, and they kind of set the ranges too. They establish limits for transmitter power output. For example, they go, okay, the City of Temple, you guys need, the fire department, you guys need a frequency. We can give you this one. You cover 50 square miles. On the other hand, Williamson County EMS, you have a dispatch center, but you guys are covering almost 300 square miles. So do you think they're going to get a higher transmitter power output than we are? Absolutely. Okay. A base station, again, is a transmitter/receiver that's at a fixed location, and it's used for dispatch, coordination, and med control. So where you might see this is just a box, it's a radio unit, and you can transmit and you can receive, okay? And it's at a fixed location. It doesn't move from there, okay? It's the geography and terrain influence the installation, so they want to put it in place that it's going to have the maximum output because it's sending stuff out, okay? It's going to get a pretty high output. It has the multi-channel bases capability, so basically it can operate several channels simultaneously. Okay, mobile units are the ones that are physically mounted in the vehicles, and they have a smaller range, 10 to 12 miles over average terrain. And again, so when you're in an ambulance or you're in a fire truck or whatever, police car, this is what you're going to have in there. So their power output is quite a bit lower than a fixed station or unit, but higher than the next one, which is a portable unit. And this is our bread and butter. We rely on these a whole bunch. These are what we call walkie-talkies, and the range is limited by the low output power, usually 1 to 5 watts. And again, with that radio, they're so good now that they have the ability to. One of the issues after 9/11, it was something called radio interoperability. Okay, the ability for me to have a portable radio, turn a band, go to a different frequency, and I could talk to the police department. Before that happened, that capability did not exist. So, the federal government said, you know what, you guys need to fix this. We want you to play fair. If you need to talk to the water department because they need a vac truck and you're working on a trench rescue, you can get on the radio and talk to them. So the radios now give us the ability to do that kind of stuff. If I'm mutual aiding with Belt and they got a bad car wreck and I need to come into their community to help them with that, I need to find out from the dispatcher what radio they're working on, frequency, and I go to that. We're all the same thing. All right, repeaters. This is a test question. Again, a repeater is extended range of mobile and portable units. Basically what it does, it receives a signal on one frequency and retransmits it to on a second frequency at a higher power. Let me ask you this. If I'm inside the grocery store and I have a portable unit and I have the fire truck outside, is the fire truck, according to this, is that a repeater?
Can be done.
It can
It
be,
can be.
absolutely. It sure can. Because it's taking that and it's picking, because the fire truck's outside and it's picking up the tower, bringing it to the fire truck, and spitting it out to me. Does that make sense? Okay. So there's kind of the view of that. All right, satellite receivers. We don't see a lot of this. It's generally where you have additional receivers located about area of desired. So it's kind of like when you have a cell phone. Sometimes you have better coverage than others. You have to have these receivers out there to pick it up and send it back. Sometimes you have what's called a remote console. Hospitals have remote consoles. In other words, when you call a hospital and say, this is the kind of case I've got coming in, you're probably talking to them on what's called a remote console. Okay, MDT on the right-hand side is, again, the little computer system we have in the apparatus, and again, that feeds us a whole bunch of information. All right, using a radio. I think it's important that before we get on the radio and you decide you want to talk and let us hear your sexy voice, you probably need to know what you're going to say before you grab the button and push the button. The worst thing you can do is pick up the radio and go, Scott and White, this is Unit 4. We're in Ratchet location with a, how old was he? Stand by. Okay, and you go, and his blood pressure, oh my God, what is his blood pressure? So, again, before you start talking on the radio, kind of be pre-scripted, know what you're going to say before you say it. It says never transmit without monitoring the frequency first. Why? Yeah, you could try to walk over other traffic. In other words, somebody's already on that frequency talking, and it's a shared frequency. So what you're going to do is kind of squash what they're saying, okay? It says wait 2 seconds after keying the microphone before talking. My example would be I get on the radio and go, Scott and Mike, this is Paramedic Vargas, and I just automatically pick up the button and I go, ass. Because I didn't wait 2 seconds, and Scott and White, this is Paramedic Vargas. Okay, all they hear is the ass. All right, so I make an ass of myself. All right, on the radio, identify yourself on every transmission. Let the doctor, nurse, whoever know who they're talking to. It says speak at close range directly into the microphone, but don't deep throat it. I mean, I've seen some people just take that thing, put it right next to their mouth, and they sound so garbled, okay? So put it at a safe distance from your ugly mug, okay? It says don't yell, use normal conversational tone and speed. Now, it's kind of hard, though, when you're excited. It's kind of hard not to. I mean, the other day when I was working that call, I'm sure I was a little excited, and I was given a lot of direction in a very short period of time. So it's kind of hard to do. It says you should use normal conversational tone and speed. You should articulate clearly and use proper English, and you should not use codes. Why should you not use codes?
Because not everybody uses the same code.
Yeah, all codes are different. Police are different from fire and blah, blah, blah. So, use of codes is probably very restrictive, and you're trying to get a message out, and the intended audience may not get it because they don't know that code. So stay away from using codes. And so I guess what we're saying on the English is use proper terminology and don't use slang terms and things like that. Again, know what you're going to say before you say it. It says that when you're transmitting information to the hospital, report the status of the ABCs and the chief complaint and the vital signs early in your transmission. And by the way, your transmission to the hospital shouldn't be a 5-minute conversation. It should be about 30 to 40 seconds. Gotten right, this is Medic Vargas. We're en route to location, working a chest pain protocol. We've initiated ACLS protocols. Be there in 2 minutes. Bam. So they know who I am, where I'm going, what kind of patient I'm doing, what kind of treatment I'm providing, based on what protocol. Does that make sense? Do they need to know any more than that? If they do, guess what? They'll ask you. Absolutely. Okay, use standard medical terminology. If you don't know the word, use plain English. Okay, if you just learned a bunch of medical terminology and you think this is the right word and it's probably not the right word. I remember the first time I picked up a patient that had overdosed on Xanax. Of course, when I first saw that word, I'm thinking, this is X-Nax. So I called and I said, this patient's overdosed on X-Nax. And you could hear him chuckling in the background. Yeah. So again, I kind of looked stupid, but it's okay. You got to be able to laugh at yourself. Okay, the next bullet says repeat all orders. Why do we need to repeat all orders?
To make sure that they understood you.
Absolutely. If the doc says, I need you to give 10 milligrams of this drug, and you go, that's a high dose. Maybe he had a brain fart. So you ask him to repeat the dose. Okay, that's why you repeat what you've heard. Okay, I understand you want me to give 0.10 milligrams, which is 0.6 milligrams more than I should give. Copy? That's what I want you to give. Okay. I can do it. Yeah, you shouldn't stop in the middle of your conversation to make sure you still have a captive audience, because I'll be honest with you, probably if you're working in the ER, what you're going to see is on those long-winded individuals they call a hospital, the nurse will pick up the thing and starts talking to you. If you're long-winded, they'll walk away from the phone. They'll come back 2 minutes later. Yeah, okay, thank you, bye. I've seen them do it. They'll walk away from a long-winded conversation, okay? Use a standard format for reporting patient information. Report the same way every time. That way you just kind of get used to how you're going to make your presentations. So that's what happens if you don't use a standard format. You just kind of get all wacky. It's kind of like doing assessments. I want you all to do assessments the same way every time. Now, when you get good at this, you can do it the way you want to, but until you get good at it, you need to follow format. Okay, it says the better the picture you can paint for the receiving personnel, the better prepared they will be to receive your patient. I used to have a lot more confidence in that statement. Nowadays, it just, you can tell them you've got something really bad, and you're going to stop at the triage nurse, and she's going to be taking her temperature and going, why are we taking this chest pain protocol and taking her temperature? They're going to do what they're going to do, okay? But if it's a major trauma patient, GSW, you'll bypass that little nurse and you go straight to Pod A, Room 1, or whatever. So again, your job is to communicate and not show off. We talked about this kind of stuff. It says identify the patient, their age, their sex, and their weight. I generally don't give weight. You can give weight if you want. Probably the nice way to give weight is based on kilogram weight. So I don't say this person weighs 300 pounds. I say this person weighs what? Is that right? Okay. What's the fastest way to determine?
Divide the weight by 2.
Hmm?
Divide the weight by 2.
2.2 is the actual number. But the easiest way to do it in your head is 300. What's half of 300?
150.
Okay. And what is 10% of 150? Subtract that from 150 and gives you what?
148.
135. Right? Subtract 15 from 150. 35, 40, 45, 50. So 135. So they weigh 135 kilos. Right? Actually 135.5. Anyway. But that's how you do it. An easy way to do it is just, you know, you can divide it by 2.2, but a lot of people can't divide by that 0.2. So, anyway. All right, patient report. These are some of the things that you want to give. And I'm going to tell you guys, please, you need to learn to streamline your conversation. Worst thing you can do is paint this beautiful 5-minute picture over the radio. You're just painting it to yourself because nobody's listening to you. Now, where's the time and place to paint that picture? Yeah, when you get to the right. And then even then you're going to be frustrated because you're giving them information and then another doc walks in and goes, what happened? So you start your story again and some other a-hole walks in and goes, wait a minute, start over. Are you kidding me? This is like the third time I'm giving this report. Okay? So. All right. Yeah. This is some of the stuff they want. But again, I would not give all this crap on the radio. Again, there's a time and place for this. Yes, like I said, this is a lot of information. And it says to give an ETA. Again, an ETA is a estimated time of arrival. Some people are really good at that, and some people are not so good at that. It's kind of hard to give an ETA when you're in the back of an ambulance and you're looking at the back one and you're going, I'm not sure where we're at. All right, if you're reporting multiple patients, you need to number each patient. In other words, it's not so common nowadays because EMS generally only transport one patient per unit. Back in the day, we would handle 3 or 4 people in the back. We'd have hangers, we'd hang them up. Hell, if you were in a wreck and you could drive, we might get you to drive the ambulance for us. Can you drive with a seat collar on? But anyway, if you're calling in reports on the patients, patient number 1 is this. Remember to complete the report on patient 1. Don't go, patient 1 has a blood pressure of this and a laceration of the head. Oh, by the way, patient number 4 also has a laceration of the head. That becomes very confusing. Complete your report on the one patient before you move on to the next one. And again, you probably need to start in the order of the most serious to the least serious when you're reporting your patients as well. Again, the radio etiquette is to be courteous. Try not to show emotion, and certainly you don't want to curse or use obscene language. You shouldn't vocalize pauses like hold on. And it says not to unkey your microphone until you have finished talking. All right, a little bit about interpersonal communications. When you're talking to somebody and they're your patient, probably the first thing that you want to do is the first thing I want to do is I want to instill confidence in that patient. I want them to quickly gain their trust. And I'm going to do that by a number of different ways. Find out who they are very quickly and address them by sir, ma'am. Introduce myself. I'm going to try and make eye contact as much as I can. That lets them know that I'm here for you and I'm listening to what you got to say. And again, remember, confidence will really inspire confidence and trust from the patient in you. Again, things like using their names unless they're told otherwise. Obviously, I'm not going to take a 4-year-old kid and call him Mr. Jones. I'm going to say Johnny, kind of thing. And condescending, yeah, that word. I can't say it for whatever. Yeah, thank you. One of the bad habits I used to have is older ladies, I'd say, honey, darling, sweetheart, babe, blah, blah, blah. And every now and again I still throw one of those out. And some of them really like that, but, you know, we're taught not to use that kind of language. Call them by their names and stuff like that. You should be conscious of and aware of cultural differences in some groups. Be courteous. Things like please and thank you and yes and no ma'am, things like that. You should be truthful. We've talked about that. And use terms that the patient family will understand. Now is not the time to open up your medical terminology bag of tricks. Okay? Now this guy, he's got issues, doesn't he? How would you like to be interviewed by him? What kind of messages is he sending out? You are wasting my time. I got steaks at the station, you know, the Mavs and the Heat are playing tonight, and you are just pulling my chain here, buddy. Okay? So, it says to be careful of what you say about the patient and where you say it. I think that's really important. And you should always be kind of aware of what your body language is saying to others. Hopefully my body language to y'all is kind of positive. Sometimes it's kind of relaxed, but most of the time it tries to be positive. It says speak slowly and enunciate and allow time for the patient to answer questions. Now who's probably going to have a delayed response?
Older folks?
Yeah. Is it because they're deaf? Yeah, they may have some hearing issues. Okay? But again, sometimes it's just that they still are sharp as they used to be. It's just their neurons are firing a little bit slower. It takes them a little bit longer to process what you're saying. Okay? So they got to kind of get all that information out from here to here, and you know there's a chain going on there. All right, what happens when we have non-English speaking patients? It says to use an interpreter. Where are we going to get an interpreter from?
Family, if they know English.
Some hospitals have them.
Okay, there's some resources. Some of the hospitals have them. Sometimes we can use a family. But what we're saying to you is, don't do what we used to do. You know, and in the old days at the hospital before HIPAA came on board, you know, if you had a patient that couldn't speak English, somebody there, maybe a custodial person, came through and they were asking me, "Can you help me to interpret?" And they were violating that HIPAA. They can't use that outlet anymore. So some of the resources available to you, there's little charts. Okay, you can get on your little phone. There's interpreter services that your organization can buy into. So you dial that number, you're paying for that service, and you say, okay, what language? Russian. Okay, stand by. They put a Russian interpreter on there for you, and they start talking to the patient, and they start, giving you the information you need. Again, do not attempt language if you're unsure. You could be talking about their mama, so be careful. There are flashcards. I mentioned that. You can use those. For the hearing impaired, again, interpreters face the patient when speaking because they have probably become very good at reading lips over time, so they probably will be able to generate what it is you're saying, and also allows them to see your facial expression. Kids, you really want to get on their level. You don't want to tower over them. You want to come up to them slowly. I mean, if you swamp a kid just right on top of them, boy, the first thing you're going to do is they're going to get into a little cocoon and dig into mom and dad and get away from you. Be careful with your postures, and you should explain things that you're going to be doing to them. Some other helpful things with kiddos: don't lie to them. You should respect their modesty. Parents are always helpful, are usually always helpful, and if they're a helpful avenue for them, then go ahead and use them. Best way to do that is let the mom and dad hold them and transport both of them, provided you could you could provide seat belts for them and things like that. What happens is the kid has a favorite little blanket that they really like. Should that go with you? You bet. With elderly, again, use their last names. Don't use your slang terminology. You shouldn't assume that they're blind, stupid, and deaf. Again, cultural differences may come into play. Don't rush the patient. We're tempted to say, come on, come on, come on, give me an answer. And be prepared to attend to their family members as well. All right. Let me see how long this last one is. What, by the way, what is for Saturday? What's on the menu for Saturday?
Scott White tour.
Lifting, moving, stair chair, scoop, and canvas tote.
Field practice, patient assessment, and vital signs.
But no lectures?
No.
Good. Yeah, we might be able to finish this real quick. All right, this is records and reports. This talks about documentation. This is an important part of what you do, guys. So the purpose of documentation, again, is to maintain continuity of patient care. There are some regulatory requirements attached to it. Quality assurance. We're making sure that we're doing the right things. Research, justification for treatment. In other words, we got a certain drug that we use, but if we're not using it, or it's no longer effective, or the commission doesn't recommend it anymore, that kind of stuff. It protects us, and there's administrative purposes behind it too. Remember, a good medical record is accurate, is good if you document facts and observations only. The worst thing you can do is get on your document, your patient care report, and start adding your opinions to it. For example, the person was intoxicated. Don't ever write the patient was intoxicated. Somebody's going to eat you alive. Because the first thing that the attorney is going to ask you is, how'd you know he was drunk? Did you test their blood alcohol level? I need to see your certification that tells me you can look at somebody and tell me that they're intoxicated, kind of thing, okay? So be careful with that. Double check numerical entries. If you gave a drug and you gave 1 milligram, make sure it says 1 milligram and not 10 milligrams. You should recheck spelling And if you make an error, you need to document it. In other words, if I gave the person the wrong drug, should I say on that document I gave the wrong drug?
Yes.
You bet. Don't ever try to hide that crap. All right, a good medical record is complete if the lines that are there to fill in. So in other words, don't leave anything blank because it makes it look like what? It was an oversight on your part. Just put doesn't apply or whatever. But don't put false information in there either. You should include at least 2 sets of vital signs on every patient. Remember, failure to document is failure to investigate. Always document your pertinent negatives. And remember this is kind of a take-home lesson. If you didn't write it down, if you didn't document it, then it wasn't done. And I'll give you a real fast example. Let's say I've taken care of a cardiac patient, and I gave them aspirin and nitro and oxygen, and did a 12-lead, and gave them morphine, and treated them perfectly. They ended up dying. They didn't die because of me. They just died. Okay? But let's say they decide to file charges, or they file a lawsuit against the fire department. And this attorney, he gets this document. He's got me in court. He goes, Mr. Varga, he goes, how long have you been a paramedic? And I tell him, and he goes, well, do you make it a common practice to not administer oxygen to your patients who are having a heart attack? I said, well, I always give my patients oxygen. Really? It seemed like you didn't give this patient oxygen. I said, what do you mean? I says, well, your document doesn't indicate that you gave me oxygen. But I did. My partner's right here. He'll tell you I gave oxygen. Again, did I give oxygen? According to that document, if I didn't document it, I didn't give oxygen. Okay? And, you know, like take-home lessons, can you remember what you did 2 years ago? Most of us can't remember. Well, y'all still can, but I can't remember what I did 2 days ago. Maybe 2 hours, too. Okay? All right, a good medical record is legible if documents presented in court must speak for themselves. In other words, somebody ought to be able to pick up my document and read through it and go, okay, I know exactly what's going on. You painted a really good picture for me. Okay? Remember, sloppy report, you got coffee stains on it, you got misspelled words on it, your penmanship sucks. A sloppy report equals sloppy care. You could be the best medic there is, but they look at your report and they're automatically going to say, you know, this guy's kind of a, you know, dink. Remember to recheck your spellings. If the document cannot be deciphered, a jury may ignore it altogether. They may see something and go, this is total crap. We're just going to throw it out. Remember, it should be free of extraneous information. You should avoid labeling the patient like this is the town drunk. Oh, really? They might be, but you don't need to put that in the report. Okay? And you should preface statements as per the witness or per the patient. You should record hearsay only if applicable. Do not record hearsay as fact. And avoid humor in the report. I had a guy one time that had a motorcycle wreck, killed his partner on the motorcycle. And his partner was obviously dead. So I'm transporting to the hospital, and he said to me, I had way too much to drink. Now, can I put that in the report? Mm-hmm. Yeah. As what? Per the patient, he expressed to me that he had way too much to drink. We all know he had too much to drink. It's 2 o'clock, 2:10 in the morning. What's he leaving? The club. Okay? All right, a good document reflects good patient care. Write a report as soon as the run as possible. Why? You know, 15 runs later, you got 15 different sets of vital signs. Are they all going to run together? Mm-hmm. And are some of these patients going to have pretty close to the same blood pressure? Yeah. Okay. If you have to make a correction, then it should be corrected. And the earlier the correction, the more reliable the change. And that last bullet is a test question. If you write something on a report and it's incorrect, what you need to do is just draw one line through it and initial it. Don't try to erase it. Don't try to white it out. Don't go back and forth with a pencil or a marker or whatever. Just one line and then make a correction and initial it. Okay, if it says if you have a long report, don't hesitate to add a secondary sheet to it because you want to make sure you get all the important information on there. Again, avoid stating diagnostic impressions like this patient was having a left lateral wall MI. I don't know. How do you know they're having left lateral wall MI? The answer is you don't. Or they've got a subdural bleed. I'm not sure. What I'm going to write on the report is what? All the signs and symptoms that tell me it's a subdural bleed, but I'm not going to diagnose this patient because I can't. Okay? And that last thing says if you must state a diagnostic impression, do so only within your scope of training. Okay, an example would be this guy had an open fracture. Don't put he had a possible open fracture. If the bones are sticking out, guess what? It's an open fracture. Thank you. And that's what it talks about. Avoid using possible or when the observation would be obvious to anyone. And that last one, if you do something to the patient, say what you did, why you did it, when you did it, and what the result was. Oh yeah, if you say, I think this patient is having a cardiac event, then make sure your protocol follows what? A cardiac event. Don't be treating them as a diabetic, okay? And that last one is something should have been done, but you didn't do it. Do you think it's important that you document why you didn't do it? Okay, don't put, just ran out of time. Don't put that. Okay, and it says if you have a prolonged scene time, say why. Because if, 2 weeks later I'm reading your report, I'm in charge of quality control or CQI, and I read this report and I see that you were on scene for 40 minutes, I'm going to, as your boss, I'm going to be wanting to know why you were on scene for 40 minutes. And the answer may be that you were on scene because we had somebody that locked themselves in a room, we had to coax them out, we had to wait for the parents to get there. You see where I'm going with that? So document that. Okay. All right, on patient refusals, perform patient assessment of the patient will allow. Remember, that needs to be one of the allowances the patient gives you. You want to try to persuade the patient to accept treatment and explain and transport if indicated, and explain, again, what's wrong, risk of not seeking treatment, benefits, and alternatives to treatment and transportation. And if the patient still refuses treatment or transport, write their decision, your assessment, and any attempts made to convince the patient to accept treatment and transport. Document patient refusal and obtain patient signature. And does the patient have to sign that document?
Yes.
They don't have to sign it. Are you going to document they didn't sign it? Absolutely. And the patient will not sign, have the document signed by a family, law enforcement, or a bystander. Okie dokie. Wow. Very good. All right. Y'all need to have that last quiz done. Well, what is it? What's the one you were working on?